health and population scientist in Nepal. We are heading toward another session of the day. As simple as it sounds, but has a great impact in uplifting one's health status. Yes, this is 9th parallel session that is all about nutrition and food safety. Thus, to proceed with, we have respected delegates to chair our session, Mr. Hira Niroula and Mr. Leela Bikram Thapa. Can we please have a round of applause? So I request you both to come up on the stage. So first, I would like to introduce you all to Mr. Hira Niroula, who is a representative member of the National Planning Commission and on the Executive Board of the Nepal Health Research Council. In this capacity, he plays a key role in influencing national health research policies and strategies. He is also a professor at Tribhuvan University, specializing in conflict, peace, and development studies. His research primarily focus on Nepal's foreign policy, examining the impact of domestic instability on global order. One of his notable academic achievements in his publication is Domestic Instability, Global Order and Nepali Foreign Policy, featured in the Journal of Foreign Affairs. He is actively involved with the Nepal Institute of Research and Innovation, contributing to research and development initiatives in Nepal. Welcome, sir. Likewise, we have Mr. Leela Bikram Thapa, who is the Chief Nutrition Officer at the Nutrition Section, Family Welfare Division, Department of Health Services, Ministry of Health and Population. With a strong background in nutrition, Mr. Thapa is dedicated in improving public health nutrition policies and in the program in Nepal. He holds an academic background from the Institute of Medicine and the Royal Tropical Institute, the Netherlands, and brings extensive experience to his leadership role in promoting nutritional health at the national level. With this, now I would like to start our session. Over to you, chairs. Thank you.
Thank you very much. म आदरणीय सरलाई चाहिँ यो चेयर यसको चाहिँ यो मेन चेयरको लागि म सरलाई म विशेष रिक्वेस्ट गर्न चाहन्छु हाम्रो राष्ट्रिय योजना आयोगका हाम्रो सुवेदी सरलाई र हजुरलाई म एकदम विशेष गर्नको लागि र म थोरै अब जस्तो यो हाम्रो जुन म नेपालीमै गर्छु म यो यहाँहरूलाई पनि म सकेसम्म यहाँहरूको आफ्नो अनुसारले कम्फर्टेबल अनुसारले प्रिफर अब यहाँले इङ्ग्लिस नै प्रिफर गर्नु छ भने त्यो समस्या छैन हैन भने नेपालीमा गर्दाखेरि अझै हामी धेरै खुल्छौँ बुझ्छौँ भन्ने मेरो आफ्नो चाहिँ यो सिद्धान्त हो। अब हामीले ओभरअल यो अहिलेको जुन यो सेसनमा हामी जुन छलफल गर्दैछौँ न्युट्रिसन एन्ड फुड सेक्युरिटी भनेको एउटा आफैमा यो क्रस कटिङ इस्यु पनि छ र एउटा ठुलो यो इस्यु र एउटा ठुलो टपिक्स पनि हो र अहिले पनि यो जस्तो यदि हामीले यो नेपालकै कुरा गर्ने हो भने पनि अलमोस्ट 4.6 मिलियन पिपुल अथवा यसलाई पर्सेन्टेजमा भन्दा 15% अफ द पपुलेसन चाहिँ फुड इन्सेक्योर अवस्थामा छन्। यो हाम्रो फिल इन द न्युट्रिएन्ट ग्याप्स भन्ने 2021 को रिपोर्टले पनि देखाएको छ र यो पनि कहाँ छ त अलि हायर उसमा कहाँ छ भन्दाखेरि प्रिभेलेन्स चाहिँ कर्णाली र सुदूरपश्चिम हाम्रो कन्ट्रीको कन्टेक्स्टमा भने अब यो फिल इन द ग्याप्स जुन 2021 को विभिन्न रिपोर्टले पनि के देखाउँछ भने अझै पनि 22% अफ द हाउस होल्ड ले चाहिँ उनीहरूले यो न्युट्रिटियस डाइट चाहिँ प्रत्येक दिन एफोर्ड गर्न सक्दैनन्। 22% यो पपुलेसनले त गर्न सक्दैनन् भन्ने छ। यो पनि सबभन्दा धेरै कहाँ छ त भने हाई यो अनएफोर्डेबिलिटी पनि सबभन्दा धेरै चाहिँ हाई इन रिमोट र माउन्टेनियस रिजन मैले अहिले पनि भने कर्णाली र सुदूरपश्चिमको उसमा छ भने यदि हामीले ओभरअल यदि हाउस होल्डको कुरा गर्दाखेरि पनि के देखियो त त्यो रिपोर्टले के देखाउँछ भने नियरली 50% हाउसहोल्ड चाहिँ फुड इन्सेक्योर एरियाजहरूमा एरियाजमा बस्न बाध्य छन् अथवा फुड इन्सेक्योर एरिया छ र उनीहरूको पनि 75% चाहिँ उनीहरूको इन्कम चाहिँ फुडमा खर्च गर्छन् भन्ने छ। अब यहाँहरूले विभिन्न अध्ययन अनुसारले के देखाएको छ भने मोर देन 40% चाहिँ यदि हाम्रो इन्कम चाहिँ फुडमा इन्भेस्ट भयो भने त्यो चाहिँ त्यसलाई चाहिँ त्यो क्राइसिस भनौँ अथवा त्यसलाई चाहिँ त्यो चाहिँ एउटा अर्कै किसिमले जुन त्यो डिनोट गरेको अर्कै किसिमका सूचकहरू छन्। अब नेपालको एनडिएचएस सर्वेमा पनि म यो सबै कुराहरू भन्दिनँ। स्टिल हाम्रो पनि अहिले अन्डर 5 चिल्ड्रेनको मालन्युट्रिसनको सिचुएसनहरू स्टन्टिङ वेस्टिङ अन्डरवेट र माइक्रोन्युट्रिएन्ट डिफिसियन्सीहरू अहिले पनि यो एनिमियाको यदि सिचुएसन हेर्ने हो भने चिल्ड्रेन एडोलेसेन्टहरूमा अझै पनि एराउन्ड 40% चाहिँ सिचुएसन छ। र अर्को चाहिँ पोर डायटेरी डाइभर्सिटीका कुरा मैले यसो रिपोर्टमा हेरेको थिएँ। ओभर 60% चिल्ड्रेन 60 to 20 per month अफ चिल्ड्रेनले चाहिँ अहिले पनि यो जुन मिनिमम डायटेरी डाइभर्सिटी भन्छौँ हामी त्यो चाहिँ खान नपाएको अथवा त्यो चाहिँ नपाएको अवस्था छ जुन हाम्रो स्ट्यान्डर्ड हेर्दाखेरि भन्ने छ। र अब क्लाइमेट रिस्ककै कुराहरू गर्दाखेरि पनि नेपाल यो चौथो ग्लोबलको ऊ अनुसार चाहिँ चौथो उसमा आउँदो रहेछ क्लाइमेटको भर्नालिबिलिटी के अरे यो भल्नरेबिलिटीमा। यसले चाहिँ के गर्छ त अब हजुर हामी सबैलाई के थाहा छ भने यसले फर्दर चाहिँ झन् वर्स्ट बनाउँछ। केलाई वर्स्ट बनाउँछ त फुड एन्ड न्युट्रिसन सेक्युरिटी अफ द कन्ट्री। ल म यो विथ दिस म यो प्रोग्राम अगाडि बढाउने अनुमति चाहन्छु र मेरो यहाँ हजुरहरूलाई सबैलाई यहाँको स्पिकरहरूलाई मेरो रिक्वेस्ट चाहिँ यो 10 मिनट भित्रमा हजुरहरूले यो प्रेजेन्टेसन गर्दाखेरि अलि धेरै त्यो प्रोसेसिङ कुराहरूलाई धेरै गर्नुभन्दा मेथोडोलोजीमा के चाहिँ गरियो अनि चाहिँ त्यसको चाहिँ अब यो रिजल्टहरू के छ र रिकमेन्डेसन के छ र अलिकति त्यो कुनै सिग्निफिकेन्ट कुराहरू छ भने चाहिँ टक्क त्यसलाई अलि मोर के अरे फोकस गर्दा चाहिँ इट वुड बी बेटर टु होइन टु हाइलाइट एन्ड फोकस अन स्पेसिफिक त्यो एरियामा मात्रै गर्नलाई मैले विशेष अनुरोध गर्न चाहन्छु। किनभने हाम्रो यो हामीलाई चाहिँ त्यो गिभन टाइमभित्रै सक्नुपर्ने चाहिँ त्यो प्रेसरले गर्दाखेरि र अलिकति केही चिज हामीले यो टाइम बचायौँ भने 2 को होइन कि 4 जना 5 जनालाई यदि क्वेसन सोध्यो भने अलिकति मोर इन्टरेक्टिभ हुन्छ भन्ने चाहिँ मेरो हजुरहरूलाई यो रिक्वेस्ट छ। ल यति भन्दै म अब यो आजको जुन यो 9th प्यारालल सेसन 9th न्युट्रिसन एन्ड फुड सेक्युरिटीको टपिक्समा हामी छलफल गर्न जाँदैछौँ र पहिलो यसको जुन स्पिकर हुनुहुन्छ हाम्रो लीला खनाल उहाँ चाहिँ पब्लिक हेल्थ प्रोफेसनल हुनुहुन्छ र उहाँको 30 वर्षभन्दा बढी यो सेक्टरमा एक्सपिरियन्स छ र उहाँले चाहिँ यो पब्लिक हेल्थ मास्टर्स इन पब्लिक हेल्थ एन्ड सोसियोलोजी र एन्थ्रोपोलोजीमा गर्नुभएको छ भने उहाँले विभिन्न सेभ द चिल्ड्रेन युनिसेफ र युएसआइडी सपोर्टेड नेपाल हेल्थ फ्यामिली हेल्थ प्रोग्राममा काम गरिसक्नु भएको छ र उहाँले अर्को एउटा चाहिँ यो नेपाल फ्यामिली हेल्थ प्रोग्रामको अन्तर्गतकै कोएक्जिडिन भनेर हामी नाभी मलम भन्छौँ त्यसमा पनि उहाँको एउटा लिडिङ रोलमा बसेर काम पनि गर्नुभएको थियो र म उहाँलाई यहाँ आएर जुन अल्टिट्युड एन्ड एनिमिया प्रिभेलेन्स को उसमा के छ भनेर यो चाहिँ सोसियो जियोग्राफिक एनालाइसिस हाम्रो 3वटा डिस्ट्रिक्ट नेपालको 3वटा डिस्ट्रिक्टमा सोसियो जियोग्राफिक एनालाइसिस भएको छ यो अल्टिट्युड एनिमियाको प्रिभेलेन्समा। त्यसको लागि म प्रेजेन्टेसन गर्नको लागि म यहाँ अगाडि ड्यासमा निम्त्याउँछु। हस् धन्यवाद। टाइम्स इज योर्स।
नमस्ते, थ्याङ्क यू एन्ड गुड आफ्टरनुन। यहाँबाट जुममा चाहिँ नि देयर आर कलिग्स जोइनिङ फ्रम जुम्स एन्ड हु इज एसोसिएटेड विथ दिस स्टडी। आई लाइक टु वेलकम Dr. Bonhart's, Eli, and my other teams member are here, and some colleagues still in the field. Basically, thank you so much for this opportunity to share. And like Leela has said that, and anemia is one of the public health problem in Nepal. So I'll talk differently today about the altitude and anemia prevalence as socio-geographical analysis in 3 districts of Nepal. It's not working. होइन नो यो क्लिकर भइरहेछ नि यो मुनिको ओके basically I don't need to disclose anything in regard of the personal conflict and relevant financial relationship with these reports. And basically, Sir has already mentioned that anemia affects over 40% of women of reproductive age of women in Nepal, and which distribution of anemia is not uniform but highly dependent upon the geographical regions. Generally, based on the NDHS, the Rai region has the highest prevalence, and we all know that it has a physical, cognitive development, economic productivity, as well as the maternal neonatal outcomes. And WHO has came with the new diagnostic standard tools for anemia, and which has been revised in 2024, and which have better normative value as well as the cutoff point apply, and based on the population living more than 1,000 meter population, and it recommendation adjustment of measurement hemoglobin value is needed. Why altitude correction is needed in the higher altitude? Because exposure to the high altitude above 100 meter stimulate production of the red blood cell, and again when exposures in the high altitude weeks and months lead to increase in red blood cell and hemoglobin. Especially people live in the high altitude resistance have a higher hemoglobin levels. However, currently many studies and data has not applied the altitude corrections and may play the significant role in the program impact. The aim of the objective is to investigate the association between geography, altitude, and socio-ethnic factor on the rates and severity of anemia. The objective was basically two objectives. One is the describe the rate of anemia in 3 district populations with using traditional methods and cutoff point. And again, another was investigate the impact of the applying WHO altitude correction measures hemoglobin in anemia, diagnostic and severity. Basically, when data was collected, it was collected through health fair, and it was screening events, and health fair was organized in the different locations of the targeted municipality. It was conducted by local health facility staff and supported by the local health municipality as well as the NGOs. And basically it was conducted in 3 districts, Humla, Nuakot and Solukhumbu. In the Humla there's a Sagigate rural municipality, Nuakot, Belgadi municipality, and Solukhumbu is Pasang Lamu. And basically initial objective is to target the women of reproductive age. However, because everybody was interested to have a hemoglobin test in the health fair, so everybody was examined irrespective of the age and gender. Basically there was, in terms of the data elements recorded, there was really limited due to the volume, and basic demographic has been captured, and especially in the pregnancy status, and hemoglobin was measured, and it was measured by portable hemoglobin measurement device, and that's called the DASPECT, which was CE and FDA approved. And for the health fair, it was obtained approval from social welfare councils, municipality, as well as the data approval was taken by the NHRC. And basically for the record, and there was a medical record created during health fair was transferred to the electronic. Again, the altitude data added during analysis, and during analysis, major hemoglobin attitude correction was applied. And again, the analysis, that's a descriptive analysis, was done, and summary static were computed, hemoglobin level, altitude, and demographic factor. And Fisher extract test was conducted to determine significance when examining the relationship between altitude and hemoglobin level. For this whole process, Global Envirotech Initiative provided technical advice to the municipalities and local NGO, especially focusing on the perinatal care, on maternal newborn care. And basically in this in this study, total 2,647 were participated or enrolled. Among them, 2,639 were analyzed. And the participants were from 159 from Humla, 1,652 from Nuakot, and 828 from Solukhumbu. And again, it was different age group, and especially in the caste, Janjati, Tamang, and Sherpa was representative. This is the result. Especially in the result, if you see the anemia result, this is before the altitude correction was applied. Result was Solukhumbu 11%, Humla 20%, and Nuakot is 61%. Let's see what happens after altitude correction has been applied. It's huge different. After altitude correction has been applied, in Solu it increases from 11 to 64%, Humla it increases from 20 to 67%, Nuakot 61 to 77%. And that that above in the overall population, if you see only from the women of reproductive age, and after altitude correction also anemia rate is from 69 to 79%, anemia prevalence among the targeted populations. Stop. Okay. And if you see the anemia male and female buses, and that's both, it's not much different. And the female is slightly anemic, but p-value is less than 0.05%. Let's discuss then. And altitude correction has a huge impact of diagnostic and management of anemia. And having said that, we have done the altitude correction in the DHA survey, but normal test, and we don't apply the altitude correction. And having said that, are we under diagnostic anemia because we don't take a altitude correction in the account? This is kind of key message. And many community-based initiatives currently do not adjust these measures. And when the big survey like DHS, they have applied in 2021, and that's finding aligned with the Cohen's and Hines finding in 1998, who found that without WHO underestimations of anemia is high altitude pregnancy cases. If we don't apply, we underestimate. And basically, another discussion point here is, basically, traditionally, we always focus on the women of reproductive age for the anemia program. However, anemia also affects all male group and in the targeted community. And another key message was, if service is available, there's a high demand for testing, irrespective of gender, caste, and ethnicity. And the next step in future countries, we are doing one field testing, non-invasive, portable point of care hemoglobin measure solutions, community-based, and this is a test is going on. This is a test in the, it's a mobile, if test retina in the, with the mobile device, you can get the hemoglobin. It still is ongoing. It will come soon. And basically, okay. There are lots of limitations in this study. I won't say this is a perfect one. This study was not designed for the research purpose. It was a basic demographic variable was conducted, and we took most of the conventional sampling. That's why you could see the lots of unequal distribution of the patient, including and between districts. Not all places and residents were coming from the have known as the recorded altitude. And we use the altitude of testing site of reference. One small effect on the overall result no social and other qualitative informations is available. No, there was another side. Okay, maybe this is an old slide, and you didn't show me the. There are some key takeaway messages from this presentation. One is like we should not only do the hemoglobin without altitude correction. Another message is we should not focus only on the female or women of reproductive age, and all gender caste line is equally vulnerable for the immunized anemia. And another message is if service is available, people use it. And basically, WHO recommendation altitude correction need to be applied in anywhere. Since Leela Sari is here from the Family Welfare Division, this is definitely policy decision and it has to be implemented all the time. And another message is for the anemia prevention, we need the multi-sectoral approach. Even Sari is here from the Planning Commission. We need to have a multi-pronged approach rather than the standalone. Thank you.
Thank you very much, Ilaji. अब यो 2023 मा यो माइक्रोन्युट्रिएन्ट फोरममा म पनि एटेन्ड गरेको थिएँ। यो त्यो बेलामा ड्राफ्ट फर्ममै थियो, त्यो बेला त्यहाँ पनि प्रेजेन्टेसन भएको थियो। अरू कन्ट्रीमा पनि यस्तै खालको यो अल्टिट्युड को र हेमोग्लोबिनलाई कसरी, यसको रिलेसनलाई कसरी गर्ने भनेर। अब यो नेपालको अहिले 2024 मा यो WHO ले यो आइसकेपछि हाम्रो कन्टेक्स्टमा पनि अब यसलाई हामीले कुनै पनि स्टडीहरू गर्दाखेरि अब हाम्रा ठुलो नेसनल लेभलको सर्वेहरूमा अब यो चाहिँ यसलाई गर्नुपर्छ, एप्लाइड गर्नुपर्छ भन्ने एकदमै पोजिटिभ स्वास्थ्य तथा जनसङ्ख्या मन्त्रालय ले अब इभन हामीले माइक्रोन्युट्रिएन्ट फोरममा गएर आइसकेपछि पनि यसका चिजहरूलाई नोट गरेर यो गर्ने भनेर अबका दिनमा हामीले यो कुराहरूलाई अगाडि बढाइसकेको छौँ भन्ने मैले यो ठ्याक्क भन्न चाहेँ। अब यसमा मैले यो डिटेल कुराहरू पछि हजुरहरूले नोट गर्नु होला। कुनै त्यस्तो जुन बर्निङ इस्युहरू, क्वेसनहरू लागेका जिज्ञासाहरूमा पछि हाम्रो प्रेजेन्टरहरूले पछि पनि जवाफ दिनुहुनेछ। अब यो एउटा चाहिँ अहिले हाम्रो यो माइक्रोन्युट्रिएन्ट डिफिसियन्सीमा स्पेसल्ली एनिमिया चाहिँ अहिले पनि हाम्रो पब्लिक हेल्थ प्रब्लमको रूपमा छ भनेर हाम्रो एउटा सिरियस पब्लिक हेल्थ प्रब्लममा छ। र यदि हामीले प्रिभिलेन्स वाइज हेर्दा पनि हायर प्रिभिलेन्सै छ सबै थ्रु आउट द सबै एज ग्रुपमा। यसलाई यो यी नयाँ इभिडेन्सहरूले चाहिँ हामीलाई पक्कै पनि केही फर्दर अब आउने स्टडीहरूलाई गर्दा केही न केही सहयोग हुनेछ। र त्यसमा अब समय समयमा भएका जुन परिमार्जनहरू, मोडिफिकेसनहरूद्वारा नै हाम्रा पनि अध्ययन अनुसन्धानलाई त्यही अनुसारले अगाडि बढ्छन् भनेर भन्न चाहेँ। अरू कुरो म पछि फेरि गर्ने नै छु। अब यो दोस्रो प्रेजेन्टरलाई म यहाँ निम्त्याउन चाहन्छु। दोस्रो यो कुसा गुरुङ हुनुहुन्छ। उहाँ चाहिँ यो माइक्रोबायोलोजी ब्याचलर्स यो माइक्रोबायोलोजीमा त्रिभुवन युनिभर्सिटीबाट गर्नुभएको छ। र उहाँ चाहिँ अहिले यो सावित्री साइन्स भन्ने उसमा चाहिँ आज रिसर्च एसिस्टेन्टको रूपमा कार्यरत हुनुहुन्छ। र उहाँले चाहिँ एन्टिबायोटिक रेसिस्टेन्स, प्रोफाइल्स अफ lactic acid bacteria labs and the bacillus को जुन स्पेरिजुलस को के यो bacillus यो उसको आइसोलेटेड फर्म अफ ट्रेडिसनल फर्मेन्टेड फुड्स र चाहिँ बिभरेजेसहरूमा यो नेपालको उसमा के छ भनेर उहाँले केही प्रेजेन्टेसन गर्नुहुन्छ। मैले यो एसपीपी भनेर मैले बुझिन सक्छु। थ्याङ्क यू भेरी मच। ल प्लिज यो टाइम स्टार्ट नाउ।
Good afternoon, respected chairs and everyone present here today. My name is Kusha Gurung, and I'm currently working as a research assistant at Savittri Sciences. It's an honor to be here at 11th National Summit of Health and Population Scientists organized by NHRC to present my work on fermented food bacteria, isolated antibiotic resistance pattern of fermented food bacteria. So before talking about my research, I would like to briefly introduce about my organization, Sabitri Sciences. Yeah, and Sabitri Sciences is a research institute based in Sanothimi, Bhaktapur since 2021. And so I would briefly like to talk about my team members. So we have Dr. Srizana Shakya. She's a research scientist. And we have Sandesh Kimire, who is a research associate. So they are the poster presenter at the summit. And I would highly encourage everyone to visit the posters and also provide valuable feedback to us. Next, my colleague Arya Gautam. She will also be presenting here shortly after this. And next, we also have our next research associate, Ashish Kewali. So he's currently working in the area of population genetics at Sabitri Sciences. Talking about our vision, I'll take the help of this tree model shown in the picture. So just like this tree needs various layers of soil to thrive healthy and to bear fruits, so our scientific ecosystem also depends upon the multiple layers of support. And so the bottommost layer represents the adults in the community, so they are mothers and healthcare workers. So the middle layer represents the high school students who are emerging scientists. And the topmost layer represents the established scientists and early career researchers. So we strive to engage with all this community so that the scientific research can flourish and grow organically in our community. So we have two ongoing projects currently. The first one, Nepal Maternal and Infant Gut Microbiome Study, NEMASIMA for short. So in this study, we aim to understand the infant gut microbiome across different lifestyles from pregnancy to 3 years of life. The second project is the Kika 1000 project. So in this project, Ki is a Limbu language. So it means a fermented that has been derived from the Limbu language, and Ka means khana in Nepali. So in this Kika 1000 project, we aim to understand the different microbial community and different health aspects of this fermented food. Now talking about my research, so the fermented food such as pickles and the beverages, they contain beneficial microorganisms such as lactic acid bacteria, bacillus, and yeast species. They also contain microbial metabolites, bioactive and nutritional compounds that are really beneficial for our health. However, recent studies has shown that these microorganisms can harbor antibiotic resistance genes, and they can potentially transfer these genes to the commensal microorganisms and food-associated pathogens. यहाँ पनि अर्कै देखाइरहेछ। So this is the overall workflow of our methodology. First, for microbial isolation. So it involves the collection of the fermented food samples, processing of these samples, and then finally storing these samples in glycerol stock for long-term preservation. For phenotypic identification, we use microscopy and biochemical test. For antibiotic susceptibility testing, we use Kirby-Bar disk diffusion method. So next is the metagenomic workflow. Since this is an ongoing project, so we are extracting DNA, and we are also carrying out metagenomics and bioinformatics in collaboration with Genetic Heritage Group, New York University, Abu Dhabi. So this slide shows the result of my research. So it shows the antibiotic resistance profile of lactic acid bacteria. So among the 28 isolate tested, all of them showed resistance towards vancomycin, and 14, 4, and then 1 isolate shows resistance towards ceftriaxone, tetracycline, and clindamycin, respectively. Next, so this is the antibiotic resistance profile of Bacillus species. So among the 8 Bacillus species, all of them shows resistance towards bacitracin. So few of the isolates also showed resistance towards ceftriaxone, clindamycin, and tetracycline, respectively. So this is the photograph of our antibiotic resistance test via Kirby-Bayer disk diffusion method. So this is the Bacillus species shown here, and the results are shown in triplicates. So in conclusion, all the antibiotics we tested in our research, so they are normally used to treat infection in the clinical settings. So we also observed the antibiotic resistance pattern of this bacteria in the antibiotic that we used. So our major takeaway is to have better regulation and a safety measure to address this burning issue of antimicrobial resistance in Nepal. In conclusion, lastly, I would like to I'd like to show sincere gratitude to my supervisor, Dr. Srijana Shakya, who is here, and also Dr. Ashish, who really helped me throughout this project, and also the entire team of Sabitri Sciences for supporting me in this research. So lastly, here's the short bio. Thank you.
Thank you very much. यो एकदमै इन्ट्रेस्टिङ र अब अहिले जुन हामी यो फर्मेन्टेड फुडको स्याम्पलहरुमा उहाँहरुले माइक्रोबियल रेसिस्टेन्सहरु के छ भनेर हेर्नुभएको छ। मलाई पनि यो मैले आज पहिलो पटक यो सुने, मैले थाहा पाएँ, किनभने यो अब यो फुडको सेफ्टी, हाइजिन र फुडको क्वालिटी का इस्युहरु अहिले हाम्रो कन्टेक्स्टमा असाध्यै यति धेरै कि त्यो हामीले कन्ट्रोल नगरिरहेको अवस्था छ र हामीले नोइङली अननोइङली त्यो चीजहरु कन्ज्युम गरिरहेको अवस्था र हेल्थको हाजार्डहरु भनौं, कन्सिक्वेन्टली हामीले विभिन्न खालको हेल्थको इस्युजहरु आइरहेको अवस्था पनि छ। किनभने हाम्रो यो जुन कृषि मन्त्रालयको अन्डरमा रहेको DFTQC द्वारा चाहिँ जुन हाम्रो यो नियमन गर्ने क्वालिटी एस्युरेन्स र विभिन्न कुराहरु जुन हेर्ने एउटा म्यान्डेट छ, त्यो स्कोप अनुसारले त्यो अझै पनि कम हेरेको छ। यसरी प्राइभेट उहाँहरु जस्तो एउटा इन्स्टिट्युटले यस्ता सानो कुराहरु गर्दै यदि हेरियो भने भोलि हामीले यो एभिडेन्सले पनि गभर्नमेन्टको पोलिसी मेकिङमा, डिसिजन मेकिङमा भोलि हाम्रो जस्तो यो विभिन्न कुराहरुलाई कसरी करेक्सन गर्न सकिन्छ भन्ने कुरो असाध्यै यो फलदायी हुनेछ भन्ने यो को भनाइ राख्दै पुनः उहाँको जुन प्रेजेन्टेसनमा पछि हामीले जुन आउने क्वेशनहरु यहाँले नोट गर्नु होला र पछि गर्नु होला। र म यो भन्दै म अब तेस्रो हाम्रो प्रस्तुतकर्ता लाई म यहाँ निम्ताउन चाहन्छु। उहाँ हुनुहुन्छ रुद्रबहादुर नेउपाने र उहाँ चाहिँ सिनियर यो डेभलपमेन्ट प्रोफेसनल यो 28 वर्षदेखि चाहिँ भन्दा धेरै पहिलादेखि विभिन्न उसमा काम गर्नुभएको छ। उहाँ चाहिँ डिजास्टर रिस्क म्यानेजमेन्ट स्पेसल्ली रुरल सेटिङमा, रुरल डेभलपमेन्टमा पनि उहाँको एउटा एक्सपर्टिज छ र उहाँ अहिले फेज नेपालमा एज अ प्रोग्राम म्यानेजरको रूपमा पनि कार्यरत हुनुहुन्छ। र म उहाँलाई यो कम्प्यारेटिभ एनालाइसिस अफ चाइल्ड न्युट्रिसन एन्ड फिडिङ प्र्याक्टिसेस इन इन्टरभेन्सन एन्ड द नन इन्टरभेन्सन एरिया यो मुगु र सिन्धुपाल्चोक जिल्लामा उहाँले गर्नुभएको एउटा स्टडीको प्रेजेन्टेसन गर्नुहुनको लागि म उहाँलाई अनुमति
Thank you, Chair.
दिन्छु।
Namaskar, everyone. I'm Rudra Neupane, working for Phase Nepal. यो स्टडी चाहिँ मुगु र सिन्धुपाल्चोकमा कम्प्यारेटिभ स्टडीको रूपमा गरेको थियो, तर आज यो डेटा जुन प्रेजेन्टेसन गर्न खोजिरहेको छौँ यसमा चाहिँ मुगुभित्रै इन्टरभेन्सन र नन इन्टरभेन्सन साइडको डेटाहरू प्रेजेन्टेसन गर्न खोजिरहेको छ। यो चाहिँ ओके, ब्याकग्राउन्डको कुरा गर्दा त अघि सुरुमै चेयरले भनिसक्नु भएको छ न्युट्रिसनको स्ट्याटस, च्यालेन्जेस, इस्युजहरू के छन् भनेर। त्यसमा म धेरै कुराहरू गर्न गर्दिनँ। त्यसमा हेर्दाखेरि अघि सरले पनि भनिसक्नुभयो, कर्णाली प्रोभिन्स प्रिभ्यालेन्सको हिसाबले हाईमा छ र त्योमध्ये पनि मुगु जिल्ला चाहिँ कर्णाली प्रोभिन्सको वान अफ द रिमोट मोस्ट जिल्ला हो र त्यसमा फुड इनसफिसियन्सी र त्यो चाहिँ डायट्री डाइभर्सिटी रिक्वायरमेन्टको मिट गर्नलाई चाहिँ जुन रिक्वायरमेन्ट चाहिन्थ्यो त्यो चाहिँ अलि निकै नै कम भएको हुनाले त्यो एरियामा हामीले काम पनि गरिरहेको छौँ र त्यही एरियाको डेटा चाहिँ यहाँ आज सेयर गर्न खोजिएको छ। आशा छ दिस विल बी भेरी युजफुल फर यु। Objectives say basically to assess the nutritional status of children under 5 and to evaluate, basically to assess the knowledge and practices of mothers and to compare the findings between intervention and non-intervention sites where PHIV is working in Mugu district. This is cross-sectional study conducted in Mugu. Mothers were the main respondents. Sample size was taken 971. Out of that 724 from intervention areas and 247 from non-intervention areas. Nearly 1/3 of the households from these areas. We selected purposely these villages, Dhainakot, Hanglu, Jima, Natharpu, and Fotu, where PHIV has been working for the last 7-8 years. And the nearby villages like Pi, Kalai, and Rara, which have similar demographic and social conditions, were selected. And data collection was mainly through the interviews and the anthropometric measurements. And data analysis is not very complicated. It's simple frequencies and percentage. Here is a little bit about PHIV Nepal. We have been working with in the region for the last almost 10 years. Basically, strengthening the primary healthcare services with the local government there. We deploy staff to be stationed in the working along with the government staff almost 3 days a week, providing clinical services, and 3 days they spend in the communities, home visits, outreach, raising awareness on all aspects of maternal and child health. Another aspect is growth and nutrition monitoring. Regularly measure the growth of the children and provide the support to malnourished children with sometimes with food packages and sometimes with home gardening support to support dietary diversities. And also we conduct frequently nutrition workshops among with the mothers and children. We also work with female community health volunteers and mothers group to raise awareness among the mothers towards the healthy behaviors and the nutrition. So this is the findings, mainly socio-demographic characteristics here. Gender, most of the respondents were female. Actually, we targeted to assess from the female, but there are some male respondents as well. Nearly 80% from the intervention areas and 94% from the non-intervention areas. Age-wise, most of the respondents were of the age 21 and 30 years in nearly similar percentage from both intervention and non-intervention areas, followed by 31 and 80 years of age. Ethnicity-wise, most of the respondents were Brahmin Kshatriya, which represents the demography of the region, followed by Dalits. It's also similar percentage, not much difference. And the literacy rate, most of the around 60+ percentage are literate and 30+ percentage are illiterate. This is also similar in both the intervention and non-intervention areas. Occupation-wise, most of the respondents are have their agriculture as the main source of income, but we can imagine that these steep terrains in Mugu, how much would be the production. Now the knowledge of mothers about the nutrition and other things. This is about the breastfeeding. We asked the mothers in the intervention areas, and they said they have to start breastfeeding within an hour. 88% of them said yes to that one. And in the non-intervention areas, it was, more than 50% said no. They were not aware of the starting breastfeeding within an hour. Exclusive breastfeeding also, knowledge-wise, in the intervention areas, more were aware, they said yes, and in the non-intervention areas, many of them were not aware. Super flour making, which is using the local ingredients. Intervention areas, 70% said they know it, and in the non-intervention areas, more than probably this frequency, yeah, 34 मात्रै says no, 93 percentage अलिकति बिग्रेको जस्तो number चाहिँ ठिकै छ, तर percentage अलि बिग्रेको जस्तो ग्राफमा. And knowledge of malnutrition, this is also better in intervention areas, nearly 73% know that one. And then golden 1,000 days, this is a little bit tricky that in the intervention areas, they less than 50% said that they know about the golden 1,000 days, but in the non-intervention areas, more of them are aware of that. And the feeding practice, next one is feeding practice. Within an hour, nearly 84% in the intervention areas started breastfeeding, but in the non-intervention area, it's different. Similarly, supplementary food, in the intervention areas, they start, most of the mothers, nearly 91% plus, started giving supplementary food after the 6 months or months, but in the non-intervention area, this number is slightly, percentage is slightly similar, but a bit less. And feeding practice, green leafy vegetables, this was one of the things. And in the intervention areas, mothers, 63% or more mothers feed their children twice or more than twice a week. But in the non-intervention area, only 50% do so. In the non-intervention areas, most of them feed once or twice a month. Similarly, feeding meat and eggs, more in the intervention areas and less in the non-intervention area. Feeding milk or milk products is also more in the intervention and less in the non-intervention areas. If you take a nutrition status, wasting, stunting, and underweight, almost similar but slightly better in intervention areas, but the percentage is very high, probably because of due to lack of sufficient food, dietary and feeding practices. PLHIV Nepal's intervention areas, so slightly better nutritional outcomes, breastfeeding practices, and dietary diversity compared to non-intervention. However, there is a lot to do, and I don't think this is just because of PLHIV. There are multiple actors working in these areas. Significant gaps remain in the complementary feeding and dietary diversity in non-intervention areas, and so that there is a need to bring more resources in these regions. These are references, and this is myself. Yeah, thank you so much.
Thank you very much for your excellent presentation. अब यो कर्णाली एउटा one of the remote province को रूपमा पनि छ र अहिले पनि यदि हजुरहरूले यो 2022 को हामीले NEHS कै डेमोग्राफिक स्ट्याटस हेर्ने हो भने पनि कर्णाली स्टन्टिङ even though we are decreasing trend in the stunting, तर अहिले पनि सबभन्दा हायर चाहिँ कर्णालीमा छ. अब उहाँको जस्तो इन्टरभेन्सन नन इन्टरभेन्सन भन्नुभयो, मलाई एउटा चाहिँ के भन्न मन लाग्यो भने सुहारा सेकेन्ड र MCHN गभर्नमेन्टले फर्टिफाइड सुपर फर्टिफाइड फ्लोर चाहिँ किनेर त्यहाँ दिन लागेको 7-8 वर्ष भयो. गएको वर्षबाट बजेटको कारणले भएको छ. त्यहाँ 6 to 23 month of children, प्रेग्नेन्ट मदर, ल्याक्टेटिङ मदरलाई प्रति महिना 3 kg का दरले सबै कर्णालीका 5 वटा जिल्लामा सबै ठाउँमा चाहिँ यो फर्टिफाइड फ्लोर दिने र प्याकेजमा ग्रोथ मोनिटरिङ गर्न लाउने, एएनसी लाई इन्क्रिमेन्ट गर्न लाउने र अलिकति हाइजिन र अरु हेल्थका अरु प्याकेजहरुमा पनि त्यो गर्ने चाहिँ त्यो एउटा प्याकेजमा जहाँ कि WFP ले होल त्यो लजिस्टिक सप्लाई र स्टोरेज म्यानेजमेन्ट चाहिँ WFP ले सपोर्ट गर्थ्यो र फर्टिफाइड फ्लोर पनि प्रोभिन्सले हाम्रो प्रोभिन्सियल यो के लजिस्टिक म्यानेजमेन्ट सेन्टरले नै किनेर यो सप्लाइजिङ गरिरहेको अवस्था छ। मैले त्यति मात्रै भन्न चाहेँ। र अब यो ओभरअल मालन्युट्रिसनको सिचुएसन हामीले अब यो अझै पनि धेरै कुराहरू गर्नु छ। हामीले अब हाई ह्याङ्गिङ फ्रुट्स के अरे लो ह्याङ्गिङ फ्रुट्स त टिप्यौँ, स्टिल अब हाई ह्याङ्गिङ फ्रुट्सको लागि चाहिँ अझै हामीले अझै माइल्स टु गो, अझ हामीले के गर्नुपर्छ भन्ने चाहिँ यो उहाँहरूको जुन थोरै एउटा सानो एउटा कम्पेरिटिभ स्टडीले पनि हामीलाई यो कुराहरू इन्डिकेट गर्छ। विथ दिस अब म अर्को प्रेजेन्टरलाई यहाँ निम्त्याउन चाहन्छु, अगाडि बोलाउन चाहन्छु। उहाँ चाहिँ अन्जिता खड्का हुनुहुन्छ। उहाँ रजिस्टर्ड नर्स, यो मास्टर्स इन फुड एन्ड न्युट्रिसन र 10 वर्षदेखिको उहाँको राम्रो एउटा अनुभव हेल्थ र न्युट्रिसनमा अनुभव छ। र उहाँ पनि कोइन्सिडेन्टली उहाँ पनि फेज नेपालमै काम गरिरहनु भएको छ। र उहाँको टपिक चाहिँ फुड इन्सिक्युरिटी एमङ द भल्नरेबल पपुलेसन्स इन इन्फर्मल सेटलमेन्ट्स अफ नेपाल भनेर यो काठमाडौँ र पोखरा भ्यालीको केही छ। के उहाँ हुनुहुन्न र हुनुहुन्छ? ए उहाँ नौनीमा पर्नु भयो उहाँ? ए त्यही त फेरि अब यहाँ म ल हस् हस् ल म गएर प्रेजेन्टेसन गर्नु होला। हस् ल धन्यवाद।
Good afternoon, everyone. Delighted to be here. I am Anjita from FAZE Nepal. We'll be presenting our research, Food Insecurity Among People Living in Informal Settlement, Insight from Kathmandu and Pokhara Valley. This research was conducted by FAZE Nepal with support from Liverpool School of Tropical Medicine under the Arise Responsive Fund. Okay. Now moving towards background, Nepal ranks 68th out of 127 countries with a score of 14.7, indicating a moderate level of hunger in the Global Hunger Index. Nepal's Constitution and Right to Food and Food Sovereignty Act 2018 recognize food security as a fundamental right. Similarly, the government of Nepal aligns with Sustainable Development Goals to eradicate hunger, improve nutrition, and ensure sustainable food production. However, poverty is one of the important determinants of food insecurity and poor nutrition. Similarly, natural disasters, landslide, and economic instability worsens the condition. Food security consists of 4 key dimensions: availability, access, utilization, and stability. Poor nutrition and food insecurity have remained challenges and impairment to development in Nepal. Rapid rural to urban migration increases informal settlements in Kathmandu and Pokhara Valley where people could get opportunities. Food insecurity is a significant public health concern in Nepal's urban informal settlements. These communities face inadequate access to food, poor living conditions, and limited health services. So, the objective of our study is to assess the prevalence and determinants of food insecurity among people living in informal settlements. Now moving towards methodology. This is a cross-sectional study and we adopted quantitative method. Informal settlement in Kathmandu and Pokhara Valley was the study site. People living in informal settlement in Kathmandu and Pokhara were the study population. Purposive selection of cities among cities followed by random selection of informal settlements in each city and selecting study population from informal settlement using simple random method. And we used household food insecurity axis scale, which is validated tool for the data collection. Descriptive analysis and binary logistic regression was done to examine association between food security and socio-economic variables using SPSS 25. Now moving towards results. Socio-demographic findings. In our study, most of the participants were female, that is 74.7%, and only 25% were male. While talking about age group, 25 to 34% were in majority, and while talking about ethnicity, more than half of the participants were Janajati, which is and followed by Dalit, 26.9%, and only minimum percentage were from Muslim. While talking about religion, most of the participants were Hindu, that is 68.3%, followed by Buddhist, 17.6%. And talking about the educational status of the participant, 61.3 were literate and 38.7 were illiterate. Among the total household of 2009, 64.8% household had food insecurity, while 35.2% still had food insecurity. That was the findings from our study. And we further categorized the food insecurity into mild, moderate, and severe, which is 13.20%, 13.80%, and 8.20% respectively. Further, we did association between food insecurity and different variables. While talking about the family type, in extended family were 1.31 times more likely to be food insecure. Similarly, in job type, participants with informal employment were significantly associated with food insecurity and 1.72 times more likely to be food insecure. While talking about monthly income, people having monthly income more than 10,000 were less likely to be food insecure. Similarly, in terms of education, higher the education level, less likely to be found food insecure, according to our study findings. Now, conclusion, addressing food insecurity in urban informal settlements require multi-sectoral collaboration involving government, NGOs, and communities. Policy advocacy is needed to improve access to food and social services, targeted support programs focusing on formal employment, enhance emergency preparedness during the disaster. I would like to acknowledge UKRI and GCRF for providing fund for this project, and I would like to acknowledge PLHIV Nepal, LSTM, and all the research team for the contribution and successful completion of this project. I appreciate the role of all the participants in the research, and I would like to thank NHRC for providing this platform for presenting this research. Thank you.
एकदम टाइमभन्दा अगाडि नै उहाँले सक्नुभएको छ, त्यसको लागि पनि उहाँलाई विशेष धन्यवाद दिन चाहन्छु। र यो मोर इनोभेटिभ र एकदम कम्प्रिहेन्सिभ र मोर इन्फर्मेटिभ हामीलाई उयोहरू दिनुभएको छ। जस्तो अहिले पनि अब म यो 35 मोर देन 35 इयर्स भएछ यो हेल्थ सेक्टरमा काम गरेको। थोरै कुराहरू सेयर गर्न मन लाग्यो यो टाइमको कुराले। जस्तो यो हामी राउटे, चेपाङ र अरू विभिन्न खालको कम्युनिटीमा हाम्रो विशेष अनुदानद्वारा राष्ट्रिय योजना आयोग र अरू हाम्रा विभिन्न प्रोग्रामहरू गइराखेको अथवा केही प्याकेजमा सोसियल सेक्युरिटीका प्रोग्रामहरू छन्। तथापि कहिले कहिले चाहिँ मलाई एकदमै इन्डिभिजुअल मेरो हुन पनि सक्छ। मलाई चाहिँ के लाग्यो भने सर्टेन कम्युनिटी जुन अब यो अहिले पनि यहाँ जनजाति र दलितहरूमा मोस्ट लाइकली टु मोर फुड इन्सेक्योर लेस अनि मोर देन 10,000 अथवा लेस देन 10,000 इन्कम मन्थली इन्कम हुनेलाई चाहिँ मोर भल्नरेबल भन्ने देखियो। तर के पाइन्छ इन जेनरल चाहिँ के पाइन्छ भन्दाखेरि अलिक धेरै मोर नम्बर अफ चिल्ड्रेन र चाहिँ अलिक अल्कोहल यो बिभरेजेसहरू चाहिँ बढी युज गरेको, उनीहरूको बिहेभियरलाई चाहिँ करेक्सन गर्ने कता कता हाम्रो विभिन्न भनौँ गभर्मेन्ट नन गभर्मेन्ट र अरू अब अहिले त जुन हामी लोकल गभर्मेन्टमा पनि छौँ र उहाँहरूको त्यो बिहेभियरलाई करेक्सन गर्ने कुरा र उहाँको मोर पार्टिसिपेटरी र एटिच्युडहरू अरू अरू चिजलाई चाहिँ इम्प्रुभ गर्ने करेक्सन गर्ने कुराहरू चाहिँ कता कता ल्याकिङ छ कि जस्तो मलाई लाग्छ है। मैले यो धेरै ठाउँमा हेर्दा एकदमै पोर हुनुहुन्छ उहाँहरू त्यस्तो छ, तर अलिकति कमाएको त्यो 10,000 कमाएको 5,000 15,000 कमाएको लेबर गरेर कमाएको चिज पनि केमा खर्च हुन्छ त भन्दा गुड्का र घुड्का उहाँलाई धेरै खानुहुन्छ, किनभने उहाँको त्यो एटिच्युडलाई पनि सुधार हुने किसिमको अथवा त्यसलाई पनि हामीले यदि त्यो पनि सँगसँगै जानुपर्छ कि भन्ने खालको चाहिँ त्यस्तो खालको मलाई चाहिँ त्यस्तो फिल हुन्छ। किनभने मैले धेरै ठाउँमा झन् 77 जिल्लामा म पुगेको छु र हामीले अहिले हाम्रो यो कन्ट्रीको विभिन्न यो इथिनिसिटी वाइज यो इस्युहरूलाई पनि एकदम पर्गलेर हेर्दाखेरि चाहिँ त्यहाँ चाहिँ हामीले अलिकति एड्रेस गर्न चाहिँ सकेको होइन कि जस्तो लाग्छ। अब यहाँ हजुरहरूले अलि पछि पनि कुरा गर्नुहोला। विथ दिस म अब हाम्रो अर्को प्रेजेन्टरलाई म यहाँ बोलाउन चाहन्छु। उहाँ हुनुहुन्छ नेहा मल्ल। उहाँ चाहिँ रजिस्टर्ड फार्मासिस्ट र कम्युनिटी न्युट्रिसनिस्ट हुनुहुन्छ र उहाँ चाहिँ को फाउन्डर र डाइरेक्टर अफ द प्रोग्राम, यो सोचाइको डाइरेक्टर प्रोग्राम हुनुहुन्छ र उहाँले यो चाहिँ हाम्रो स्वास्थ्य तथा जनसङ्ख्या मन्त्रालय परिवार कल्याण महाशाखा मेरै सेक्सनको नेतृत्वमा पनि उहाँहरूले जुन एउटा हामीले युनिसेफको सहयोगमा चाहिँ एडोलेसेन्ट यो स्कुलको चाहिँ विभिन्न करिकुलमहरूलाई एड्रेस गर्ने र एउटा स्कुल बेस इन्टरभेन्सन यदि गर्न सक्यौँ भने हामीले कुनै केही चिजहरूलाई अलिकति इम्प्रुभ गर्न सक्छौँ कि भनेर एकदम सर्लाएका केही स्कुलहरूमा चाहिँ रुरल र अर्बन स्कुलमा चाहिँ अलिकति इन्टरभेन्सन हेरेका थियौँ र एउटा उहाँलाई यो प्रेजेन्टेसन गर्ने म अनुमति चाहन्छु। हस्, धन्यवाद।
Thank you, sir. Respected chairs, fellow presenters, and members of the audience, I'd like to wish you a very good afternoon. I am Neha Malla, representing Soaltee as the co-founder and director of programs. And today I'm presenting on the study, Effect of Adolescent-Led School-Based Intervention for Improving Adolescent Nutrition in Selected Schools of Soaltee District, a Mixed Method Study. Acknowledging the work of our co-authors from Soaltee as well as our study partner Health Action and Research, to set the context, as we all know, adolescence has been identified as the second window of opportunity for correcting nutritional adequacies and laying the groundwork for lifelong health in adulthood. And in line with that, the government of Nepal has enacted several policies, plans, and programs that underscore the government's commitment to improve it. However, despite all these efforts, malnutrition in adolescents remains a major challenge in Nepal. According to the National Micronutrient Status Survey of 2016, 32% of adolescents are stunted, 20.5% of adolescent girls in Nepal are anemic, and all adolescent boys and girls, almost below 50% of them, fail to meet the required minimum dietary diversity. Also, according to a study by UNICEF in 2016, only 17% of adolescents were participating in the school health and nutrition programs, which makes it a big missed opportunity for nutrition education delivery in children and adolescents. Hence, adolescents yet being a vital and untapped resource for progress in this factor, it is found that they will need information and ample opportunities to engage in shaping the interventions that it provides the enhancement of nutritional programs in their schools and communities. Hence, this study was designed to examine the effect of an adolescent-led school-based intervention that aimed in improving nutritional outcomes among adolescents in the selected schools within the 3 municipalities in Soaltee district in Mahesh, which is one of the areas with the highest rates of undernutrition and anemia in Nepal. This study was a part of the project Poshan, as Leela sir also mentioned in the beginning, which was led by the Family Welfare Division Nutrition Section with the support of UNICEF and NORAD, implemented by Soaltee, which had the objectives of improving nutrition knowledge, dietary diversity, nutrition status, health knowledge and hygiene practices in these adolescents, as well as improvement of the coverage and awareness of the National Weekly Iron Folic Acid Supplementation and Deworming Program. The study also aimed to examine the access and consumption of unhealthy food in these adolescents. For this, the intervention that was designed by Soaltee was the use of Soaltee's flagship innovation tools, the NutriBeads and Red Cycle bracelet, as well as the development of a 4-day adolescent nutrition training module, along with the innovative iron folic acid bracelet and the self-tracking tool, Daily Food Journal. This intervention was designed with the coordination of government stakeholders at the central, provincial, and local level, and it was administered at the selected schools at Hariwan, Bagmati, and Barathwa municipality. These design tools were then implemented through a 4-day nutrition and hygiene bootcamp training program across these 5 schools, and 25 adolescents were then trained in each of these 5 schools, who then engaged in the nutrition club to implement the intervention across the 9 months. Talking about the methodology, this was a quasi-experimental design mixed method study on which the quantitative part utilized data from adolescent students studying in grade 7, 8, and 9 of the selected 5 intervention and 5 control schools, and the quantitative data was analyzed by bivariate and multivariate analysis using the generalized estimating equation model, the GEE. For the qualitative part, we utilized the key informant interview method with stakeholders at schools, community, and local level government, and FGDs with the school-going adolescent, out-of-school adolescents, and their parents. And for its analysis, we utilized the thematic analysis and the most significant change stories method. The flowchart of our methodology, wherein the qualitative and quantitative findings, as well as the most significant change stories, were triangulated to compile the results. Moving on to the results, for the quantitative part, our study found out that amongst the study population of the adolescents at school, 10% of the females and 39% of the male respondents were found to be underweight. 75% of the adolescent respondents consumed sugary foods, beverages, highly ultra-processed food in the past 24 hours of the survey, and almost 35% of adolescents regularly consumed unhealthy, ultra-processed food from local shops, stalls and markets nearby the schools in the tiffin break. Also, it was found that 57% of the adolescents girls were consuming the iron and folic acid IFA tablets as per the schedule, and 69% of the respondents were consuming the albendazole tablet as part of the deworming program. Also, it was found that 79% of these adolescents had an access to a smartphone and 84% with internet access. In the quantitative findings of the BMI according to age scores, there wasn't found to be any significant difference between the baseline and the follow-up in between the adolescents, as the DID, difference in difference coefficient, was not found to be significantly different. But however, there was improvement in awareness and the coverage of the iron and folic acid intake, as well as awareness and improvement in coverage of the deworming program, as well as in the consumption of healthy food in schools. So similar to the DID coefficient analysis, it was found that the dietary diversity score had improved from the baseline to the end line with a significant difference, and there was a significant improvement in the awareness of the IFA program, the coverage of the IFA and deworming, as well as the consumption of healthy foods among the school children. As for the qualitative findings, it reflected and resonated the quantitative findings as well. The results of the KII and FGD implied that there was improvement in adolescent-led efforts for implementing school-based activities, targeting coverage of IFN and deworming program, as well as raising awareness on nutrition and health issues. Also, there was improvement in implementation and monitoring of the IFA program in the community as well through the school-led intervention. Also, there was improved awareness and attitude towards the school health and nutrition program from the overall stakeholders at the schools as well as the local government, the ward office, as in the municipal health and education sections. There was also positive findings in the involvement of parents and community for school-based activities for sustained behavior change. And the study also found out that there was need of additional efforts, particularly for the inclusion of socio-economically disadvantaged and vulnerable groups such as Dalit, Muslim, and indigenous communities living in Bangladesh. Finally, school teachers and local leaders from the municipalities were also recognized as key players and primary drivers to ensure the sustainability of this kind of intervention. In concluding the study findings, it was found that the intervention was successful in creating a positive effect on IFA distribution and awareness, raising awareness about the deworming, as well as reducing consumption of unhealthy food. However, due to limited time frame, we couldn't find any significant effect on nutrition status, nutritional knowledge, health knowledge, or hygiene practices. Hence, we also felt in accordance to the study findings that there is a strong need of establishing school-based interventions with the community if we are to carry out long-term behavior change objectives with a longer intervention and timely follow-up monitoring in between. To conclude, the takeaway message, the study findings and our team's recommendation to the government and administrative bodies is that capacitating and engaging adolescents as change agents as the drivers of implementation and improvement of adolescent nutrition can be a key factor, as well as utilizing innovative approaches in designing localized intervention can bring together parents, teachers, and other multi-sectoral actors to sensitize them on the importance of nutrition, as well as integration of WIFAS, menstrual hygiene day, hand washing day, and annual deworming programs can be good entry points to implement these kind of national and local campaigns. Finally, I would like to thank the Family Welfare Division, especially the nutrition section from DOHS, UNICEF, and NORAD for the support of the study. Thank you very much for your time. This is my finding. Thank you so much.
Thank you very much, Nehaji, for your impressive presentation. अब यसमा चाहिँ अब हामीले अर्को पनि के एउटा हेरेका थियौँ भने जुन शिक्षा मन्त्रालयद्वारा जुन भएको मिड डे मिलमा जुन एक किसिमको अब बिस्किट दिन्छन्, चिउरा दिन्छन्, के भन्ने कुरामा नि हामीले यो प्रोग्राम इन्टरभेन्सन भएका स्कुलहरूमा चाहिँ अलिकति इम्प्रुभमेन्ट चाहिँ फर द टाइम बिङ अब यो लङ टर्म गर्न सकेको अवस्था भएन र यो पछि हामीले अरूको एउटा हामीलाई के सिकाइ भयो भने हामीले यो शिक्षा विभागसँग अब अर्को नाम छ अहिले शिक्षा विभागसँग समन्वय गरेर हामीले अब यो 8, 9 र 10 ग्रेडको करिकुलममा चाहिँ उनीहरूको त्यो दिएको क्रेडिट आवरभित्र पनि न्युट्रिसनको कन्टेन्टहरूलाई अलिकति अहिलेको यो लेटेस्ट कन्टेन्टहरूलाई चाहिँ त्यहाँ राख्नलाई 8 कक्षामा त राखिसक्यौँ। इभन ब्रेस्ट फिडिङको इम्पोर्टेन्स पनि के हो भनेर त्यसरी पनि राखेका छौँ। यसरी यो चाहिँ हामीले अहिले सुरु गरेका छौँ। मिनिस्ट्री अफ एजुकेसनसँग सँगै बसेर बिस्तारै यसको चेन्जको क्रममा पनि हामी गएको छौँ। यसले एउटा चाहिँ गर्यो र यसले अब अर्को यो कहाँसँग हामीले यसलाई लिङ्क गर्दैछौँ भने अब हजुरहरूले यहाँ सुन्नुभएको होला हाम्रो स्कुल हेल्थ नर्स जुन हाम्रो नर्स छन्, विद्यालय नर्स सबै ठाउँमा छैनन्। बागमती प्रोभिन्समा र सर्टेन प्रोभिन्सले नै उहाँहरूलाई जुन नर्सले एज अ कि एक्टरको रूपमा जुन काम गर्नुभएको छ, कभरेज आइएफए जुन विकली आइरन फोलिक एसिड सप्लिमेन्टेसन होस्, अरू पनि कुनै पनि हाम्रो एचपिभी भ्याक्सिनेसनको होस्, हेल्थका अरू प्रोग्राममा पनि रेकर्डिङ रिपोर्टिङ गर्ने र सर्टेन कुराहरूको चाहिँ स्कुलमा केही कुराहरू सिकाउनको लागि बिहेभियरल चेन्जमा मोर फोकस गर्नको लागि त्यो पनि गर्दैछौँ र मिनिस्ट्रियल लेभलमा यहाँले सुन्नु पनि भएको छ पक्कै पनि समाचारमा हाम्रो स्वास्थ्य मन्त्रीज्यू र शिक्षा मन्त्रीज्यूको ले अहिलेको जुन यो अहिलेको ऐन जुन अहिले यो विभिन्न कुराहरू ऐन आउने क्रममा छ यो चाहिँ के अरे इलेक्टिभ सब्जेक्ट रहेछ स्वास्थ्य चाहिँ यो पब्लिक स्कुलमा इलेक्टिभ होइन यो स्वास्थ्य त सबैले पढ्नै पर्छ भनेर त्यहाँ राख्न पनि अहिले यहाँ चाहिँ लबिङ चाहिँ भइरहेको कुराहरू म हजुरहरूलाई जानकारी गराउँछु हस् त ल म अब हामी जहाँसम्म लाग्छ हामी एकदम टाइममै छौँ त्यसले गर्दा हामी अहिले अलिकति इन्ट्रेक्सन अलि मोर इन्ट्रेक्टिभ सेसनमा हामी पछि जानेछौँ अब म हाम्रो यो अनुषा आचार्य जो चाहिँ यो हाम्रो मास्टर इन पब्लिक हेल्थ रहेछ उहाँ चाहिँ 8औं वर्षदेखि यो क्लिनिकल नर्सिङको एक्सपिरियन्सहरू गरिरहनु भएको छ र उहाँ अहिले लेक्चरर एज अ लेक्चरर पनि BPHR कान्तिपुर एकाडेमी अफ हेल्थ साइन्समा गर्दै हुनुहुन्छ उहाँले यो न्युट्रिसनल नलेज एन्ड डायटरी एडिरेन्स एमङ द हाइपरटेन्सिभ पेसेन्ट्स इन ललितपुर भनेर उहाँको एउटा यो पेपर छ उहाँलाई प्रेजेन्टेसनको लागि म अनुमति चाहन्छु हस् धन्यवाद
Thank you, sir. Good afternoon, everyone. I am Anusha Acharya. Currently, I am engaged as a lecturer in Kantipur Academy of Health Science. Firstly, I would like to thank NHRC for providing this opportunity for the oral presentation. And the topic of my research is nutrition knowledge and dietary adherence among hypertensive patients in Lalitpur. As we all know that hypertension concern is growing globally due to its association with increased rate of illness, death, disability, and financial burden. It is considered the most significant and easily adjustable risk factor for heart problems, stroke, kidney problems, and eye diseases. A population-based study conducted in Nepal in 2080 has found that hypertension prevalence among Nepalese individuals over the age of 18 was 44.2%. The multi-sector action plan for Nepal, the multi-sector action plan for NCD Nepal aims to reduce the prevalence of hypertension by 25% by 2025 with the target national prevalence of 19.3 in 2025. Despite the most successful way to manage the hypertension is through lifestyle changes, particularly dietary changes and increased exercise. Research has shown that dietary approach to stop hypertension diet is an effective method for both preventing and treating the hypertension. The NCD's risk factor step survey Nepal 2018 had also showed that 96.7% of Nepalese adults had an inadequate intake of fruits, vegetables, and consume more salt than the recommended daily amount. However, despite the rising prevalence of hypertension in Nepal, research on knowledge and adherence to DASH diet is limited. So this study evaluated the knowledge and adherence to DASH diet among hypertensive patients in Lalitpur and the factor influencing them. Dependent variables of this study was age, sex, marital status, family type, religion, education, occupation. Clinical factors like hypertension, duration, awareness of blood pressure level, drug therapy, family history, and behavioral factors like habit history of smoking, habit history of alcohol, daily walk for 30 to 60 minutes, and counseling by medical personnel, nutritionist are the independent variables. Similarly, barriers to adherence to DASH diet like poor knowledge to prepare right food, feeling of tasteless food, difficulty in changing old dietary habit, poor family support, availability of food, affordability of food, lack of time to prepare food are some of the barriers. And for the self-efficacy, limit salt intake, control overeating, eating adequate fruits and vegetables, limit saturated fat, limit sweetened beverages and sweets, limit intake of processed food, reduce intake of oily food, and not eating restaurant foods were also included as independent variable in this study. And the dependent variables of the study are knowledge of desk diet and adherence to desk diet. General objective of the study is to find out the knowledge, adherence, and associated factor of desk diet among hypertensive patients, and the specific objective are to assess the level of knowledge of hypertension, to determine the factor associated with the level of knowledge of hypertension, to assess the level of knowledge of desk diet, to determine the factor associated with knowledge of desk diet, to find out level of adherence to desk diet, and to determine the factor associated with adherence of desk diet among hypertensive patients. Moving towards the methodology, this study adopted cross-sectional descriptive analytical design with quantitative approach. Study area was outpatient department of KIST Medical College and Teaching Hospital, and study population were hypertensive patient age 20 to 59 years old who visited KIST Medical College and Teaching Hospital OPD from 6th November 2022 to 18th January 2023. Systematic random sampling with a sampling interval of 2 was used for collecting the sample or participant. The calculated sample size of the study was 308, but after the 18 refusal, the final sample size was 290. All the hypertensive patients aged 20 to 59 years old who visited OPD of KIST Medical Hospital who had been diagnosed with hypertension for at least 1 year and who gave the written consent to participate were included in the study, whereas hypertensive patients, those who had the comorbid conditions like diabetes, ESRD, psychotic disorder, and pregnant were excluded. For the validity and reliability, structure questionnaire were adapted from the previous study, and necessary modification was done based on the pre-testing and through the feedback of practicing cardiologists and nutritionists. Similarly, Cornbreck alpha test was used for the internal consistency. Face-to-face interview were conducted using structure questionnaire to collect the participant information related to socio-demographic information, knowledge of hypertension, desk diet, and diet adherence. Similarly, data was edited, cleaning, and processed and analyzed by using SPSS version 25. For scoring technique, 1 point was given for every correct answer. Adherence to desk diet was checked by using 5-point Likert scale, which was from never to nearly always, and scored from 0 to 4. Reverse coding was done on need. Marks scored related to the knowledge and adherence were changed to percentage. After that, based on the operational definition, level of knowledge was ranked as low, average, and high. Similarly, adherence to desk diet was ranked as adherence and non-adherence. For descriptive analysis, frequency, percentage mean, and standard deviation was used. Pearson chi-square test, odd ratio was used for bivariate analysis, and multivariate binary logistic regression was used for multivariate analysis. As the study is cross-sectional, it was difficult to establish cause-effect relationship. There was also chances of modification of dietary practices by the participant, and the food amount and serving frequency completely relied on individual subjective concept. These all are the limitation of the study. For the ethical consideration, ethical approval was taken from IRC, Board of KIST Medical College and Teaching Hospital, and informed written voluntary consent was taken from all participants. Moving toward the results, let us talk about the knowledge of hypertension. The study shows that majority of the respondents had a high level of knowledge, and only an insignificant number of the respondents had low level of knowledge regarding hypertension. And by studying deep, the study concluded that only one variable as a significant factor related for the knowledge of association, and it was religion. The study shows that Hindu were 5.3 times more likely to have hypertension knowledge than the respondent following all religion. The level of knowledge of respondent regarding healthy diet is seen as declining in comparison to level of knowledge to hypertension, such that study shows that only 46% of respondents have high knowledge related to the desk diet, and just more than half of the respondents have knowledge up to the 70%. Similarly, factors like having at least secondary education, being aware of one's blood pressure level, having no habit history of smoking, possessing high knowledge of hypertension were found statistically significant with knowledge of DASH diet. Now let us talk about the level of adherence of DASH diet. The study showed that majority of the respondents, that is 59%, had not adherence to the DASH diet, and the factors responsible were hypertension duration, high DASH knowledge, and high self-efficacy. Let us conclude the presentations. As the hypertension is increasing burden to the humankind, it is essentially to effectively manage it. The study conclude that majority of the respondents were not adherents to the DASH diet despite of having high level of knowledge regarding to hypertension and high level of knowledge regarding to the DASH diet. Previously mentioned predictor of adherence to DASH diet such as the longer duration of hypertension, knowledge of DASH diet, self-efficacy in following dietary therapy, all are related to the health education and disease and the corresponding dietary treatment. Therefore, implementing strategies to enhance understanding of hypertension, DASH diet along with boosting self-efficacy could be beneficial for improving the health of hypertensive patient. This is my short bio. Thank you.
Thank you very much for your comprehensive presentation. बिहानको यो हाम्रो ठुलो लार्ज ग्रुपमा एउटा कुरा आएको थियो, हस्पिटल बेसमा चाहिँ किन रिसर्च हुँदैन भने यो एउटा यस्ता धेरै छन् होला, तर अहिले हामीले यो सेसनमा चाहिँ एउटा वान अफ द यो बेस्ट एक्जाम्पल पनि हो, यसरी हुन सुरु गरेका छन् र यो चाहिँ असाध्यै राम्रो र क्लिनिकल्ली र एक्सपिरियन्स मान्छेहरूले गर्यो भने हामीले कुनै इभिडेन्स चाहिँ सजिलैसँग काहीँ नगइकन कस्ट इफेक्टिभ वेमै हामीले त्यो यस्ता चिजहरू गर्न सक्छौँ भन्ने एउटा राम्रो एउटा उदाहरण हो। अब म लास्ट, अब हामीसँग एकजना लास्ट स्पिकर हुनुहुन्छ आर्य गौतम। उहाँ पनि सावित्री साइन्स भक्तपुरमा हुनुहुन्छ। उहाँ चाहिँ स्पेसलाइजेसन चाहिँ उहाँको माइक्रोबियल कम्युनिटीमा छ र साइन्टिफिक एडभोकेसी को छ र उहाँले चाहिँ इकोलोजिकल फ्याक्टर that drive the microbial communities in the culturally diverse fermented foods. अघि पनि fermented foods को कुरामा थियो, अब अझै यसले culturally diverted उसमा चाहिँ के छ भनेर उहाँलाई प्रेजेन्ट गर्ने म अनुमति दिन चाहन्छु। हस्, धन्यवाद।
Good afternoon, respected Chair, Vice Chair, my fellow delegates, and each one of you present here. So it gives me great delight to be presenting my research titled Ecological Factors That Drive Microbial Communities in Traditionally Fermented Foods. So सुरु गर्नुभन्दा अगाडि चाहिँ I just like by answering why fermented foods, what's the significance of studying fermented foods. So पहिलो चाहिँ fermented foods occupy a very important role in many cultures around the world, including our own. And increasingly fermented foods are also being recognized to confer various health benefits. So they're enriched in various kinds of vitamins, amino acids, and various other metabolites that are known to contribute to our health. And food fermentation also offers a very sustainable alternative to food production. And so for this reason, we believe that fermented foods can be used to combat global issues like food insecurity, but also combat issues like malnutrition in Nepal. And so in this study, we were primarily interested in understanding what the microbial composition of these fermented foods are. So before I go to my results, I'd just like to take a moment here to share the fact that in addition to our scientific research, community engagement remains central to our work. These are a few snapshots of us sharing our work with the community, sharing our results with them, as well as integrating their knowledge, local and indigenous practices into our scientific research. Now moving on to my actual research, so we actually collected 90 different samples from 29 fermented foods. So these were foods like gundruk, simki, various kinds of achar, tama, as well as other foods from other parts of the world like Korean kimchi, Kazakh cheese, and so on. And so these foods had different preparation methods. Some of them used salt, oil, spices, others didn't. They were fermented for various amounts of time, and they were also exposed differently to the environment. Some were sun-dried, some were not. So we basically extracted their DNA and studied what are the bacterial and fungal communities found in these foods. So what did we find? We found this very diverse group of bacteria in our fermented food. So this is a tree of all the bacteria that we found. And as complex as this looks, यसको एउटा key message चाहिँ के हो भने usually fermented foods को studyहरुमा चाहिँ the main focus only has been lactic acid bacteria. तर हामीले चाहिँ हाम्रो studyमा we found these additional microbes such as bifidobacteria, pantoia, brevibacterium, corynebacterium that are less known in the context of food fermentation. यिनीहरुले के गरिरहेछ, role के होला भनेर चाहिँ there's not much in the scientific literature. So this points to the necessity of sort of focusing on these other kinds of bacteria. And likewise, these are all the fungi that we found. The fungi we usually focus on yeasts, but we also found these other fungi like Rhizopus, Mucor, etc. that might play very important roles in food fermentation as well as food safety. So next, we also did a principal coordinate analysis where if you look to the plot on the left, यो प्लटमा चाहिँ हरेक डट भनेको एउटा पर्टिकुलर फुड हो र त्यो दुईटा डट नजिकै भएको भनेको चाहिँ तिनीहरुमा भएको ब्याक्टेरियल कम्युनिटी चाहिँ उस्तै उस्तै भएको भनेर जनाइन्छ है. So we find 4 main clusters here हैन. तलको पट्टिको cluster 2 मा चाहिँ सबै डेरी फुड्सहरु पर्छ. सो दही, चीज यिनीहरु. माथि क्लस्टर 3 मा चाहिँ त्यो रातो कलर भएको क्लस्टरमा चाहिँ दे आर मेनली प्रोटीन रिच फुड्स सच एज मस्यौरा, सुकुटी यिनीहरु. एन्ड देन द क्लस्टर 1 and 4 जुन चाहिँ ग्रीन छ they are mostly vegetable ferments such as gundruk, tama, etc. And so what we find is that these fermented foods are basically separated by substrate. So we find that dairy ma चाहिँ we have these bacteria such as Streptococcus, Staphylococcus, Corynebacterium. Meat, legumes we mostly have Bacillus. And vegetable ferments we have various kinds of lactic acid bacteria. But on the other hand, when we look at the fungal communities, we don't find substrate dependency. So यो अघिको चाहिँ bacterial community ले drive गरेको variation भयो. This one is variation drive by the fungal communities, and here we don't find substrate dependency. So there are 3 main clusters, but they're not separated by substrate. So the fungal communities found in these foods were more substrate independent. And so cluster 1 there are mainly yeast such as Debaromyces, etc. And then cluster 3 had more Rhizopus, Mucor, and these other kinds of filamentous fungi. Okay, so this is what were present in these fermented foods. That what are they doing is also more important, right? Bacteria, fungi ke garracha, ke produce garracha bhanera. Say we can also predict that from their DNA. And when we look at that, so we find these various functions being enriched in these fermented foods. So various kinds of amino acid metabolism such as glycine, valine, leucine, arginine, yिनीहरुको metabolism, synthesis, biosynthesis, we find it being higher in dairy as well as legume-based fermented food. And it makes sense because the macronutrient composition of dairy and legumes and meat, they have higher protein. So the kind of bacteria that were found in these foods were more prolific in breaking down protein, as opposed to the bacteria we found in vegetable ferments, which have higher carbohydrates. And so hence these bacteria were better at breaking down carbohydrates and synthesizing various metabolites from it. So we also see various health relevant functions that are active in these fermented foods, such as thiamine metabolism, retinol metabolism, folate metabolism, vitamin B6 metabolism. So these functions, so the bacteria present in these foods are also synthesizing these various vitamins and macro and micronutrients. Finally, when you look at all the bacteria as well as fungi together, we see this very densely connected network, right? So यसमा चाहिँ हरेक circle represents a particular microbe, either bacteria or fungi. अनि यसमा पनि we find substrate dependency. So त्यो माथिको pink cluster are all bacteria, all fungi, and the purple cluster are all bacteria. र त्यो दुईटा kind of ecology, we find it being enriched in all of our dairy products. So fermented foods like dahi, cheese, etc. And then if you look to the right, so the green color ko duita cluster of bacteria and fungi, they're enriched in meats and legumes. And then finally, if you look at the blue and cyan community in the bottom, those ones were enriched in vegetables such as gundruk, sinki, etc. And so what we found was it wasn't just one or two bacteria or fungi that were different in fermented foods, but the whole ecosystem was different, right? So the fermented foods consumed that say, okay, because we know they're important for our health, मैले दही मात्र खाछु so मलाई पुग्छ भन्ने चाहिँ मिलेन, because we're seeing very different kinds of ecosystems in different kinds of fermented foods. So vegetables are एउटा थरी in gundruk, sinki, etc. Dairy अर्को थरी, दही, cheese, etc. And legumes मस्यौरा, सुकुटी यिनीहरू अर्कै थरी. So यो तीनटा खालको फुडमा चाहिँ हामीले different खालको चाहिँ bacteria र fungi भेट्यौँ, which are all doing different things but important things for our health. Okay. Now basically to conclude, so हाम्रो major conclusions चाहिँ के हो त भन्दा, first we find that these traditionally fermented foods are host to a very diverse group of bacteria and fungi, जसको चाहिँ many of whose roles are not fully understood. So मैले first मा भने जस्तै lactic acid bacteria र yeast भन्दा बाहिरको अरू पनि we found this diverse group of bacteria and fungi that we don't know what they do. So it's important to sort of study them, focus on them, and diversify our food microbiome. Second, we found that substrate plays a very large role in determining the microbial communities of these foods. And third is, we only did 16S and ITS sequencing, but doing a larger, so doing metagenomic sequencing of a large diverse group of fermented foods, as well as some in vitro experiments such as culturing experiments, will enable identification of specific microbes who can then be utilized to prepare fermented foods with optimal flavor, design, and health benefits. In the context of हाम्रो आजको discussion, where multiple presenters have talked about sort of dietary interventions, etc. We believe that so interventions instead of providing these packet supplements to communities that we've often found that they're not fully receptive to, randomly powder there might not be a very high adherence to following those interventions. But if you fortify fermented foods, which are very culturally relevant, it can better be used to sort of combat nutritional inadequacies and malnutrition. So that brings me to the end of my presentation. Thank you. These are all my acknowledgements.
Yes, thank you very much. I'm like the right time I'm like सकेका छौं म सबै प्रेजेन्टरलाई पुनः एकपटक हामीले 6 वटा प्रेजेन्टेसन सुन्यौं अलिकति टाइमको हाम्रो कन्स्टेन्टले हामी त्यही अनुसारले गर्यौं सबै प्रेजेन्टरहरूलाई म एकदमै यो हामी यहाँ ड्यासमा हाम्रो सुवेदी आदरणीय सुवेदी सर र मेरो तर्फबाट म धेरै धेरै धन्यवाद दिन चाहन्छु र अब थोरै हामीसँग टाइम पनि छ त्यो टाइमलाई अलिकति इन्टरेक्टिभ बनाऊ भन्ने मेरो सुरुदेखिको सोच पनि हो अब कम्तीमा पनि सुरुमा म यो 3 वटा क्वेशन्स यहाँ हजुरले ह्यान्ड रेज गर्नु होला र यहाँले यदि टिप्नु भएको छ क्वेशन टिप्नु भएको छ नि कसलाई पोइन्ट गर्ने एउटा यहाँले भन्नु होला र म सर्वप्रथम त हाम्रो सबै प्रेजेन्टरलाई म अगाडिको रोमा आएर म बसिदिन पहिला म अनुरोध गर्न चाहन्छु ल अगाडिको रोमा आएर बसिदिनु होला ल हजुरहरुको क्वेशन्स 3 वटा म सुरुमा म 3 वटा लिन्छु अलिकति यहाँ टाइम हेर्छु टाइम अनुसारले पछि म्यानेज गरौँला ल feel free to frank any sort of questions policy level questions अब scientific research evidence innovative creative कुराहरु कति चीजले अझै नयाँ अब यो अझै नयाँ फर्दर स्टडी गर्नुपर्छ भन्ने अहिले जुन लास्ट प्रेजेन्टेसन उहाँले गर्नुभयो हामीले थाहा नभएको कुरा अननोन चीजहरु हैन मोर ब्याक्टेरिया र यो फंगल ग्रुप्सको वेहरु पनि देख्यौं त्यसले फर्दर अब हेल्थमा रिस्क के छ भनेर फर्दर गर्नुपर्ने कुराहरु छन् ल म हजुरहरुको फ्लोर यो फ्लोरमा म ओपन गर्न चाहन्छु र फ्लोरबाट क्वेशन्स कसैको 3 जनाको म सुरुमा लिन चाहन्छु ल प्लिज raise your hand and ask specific questions to presenter फिडब्याक पनि हुनसक्छ अनि यहाँहरूले पोलिसीलाई हामीलाई पनि फिडब्याक दिनुभन्छ यो मैले चाहिँ के धेरै कुराहरू यहाँ सिकि पनि राखेको छु धेरै कुराहरू जानी पनि राखेको छु कहिले कहिले ठुल्ठुला कुरा गर्छौँ हामी तर सानो कुरा एकदमै गर्न सकिने कुरा सानो कुराले धेरै चेन्ज आउने कुरा पनि यहाँ धेरै अहिले यो उहाँहरूले सेयर पनि गर्नुभएको छ ल प्लिज बरु उहाँलाई माइक चाहिँ दिनु होला प्लिज हस्
Thank you. I'm asking to the Hira Madam about altitude and anemia. First presentation. I'm from collaboration research by Pokhara University and Kansai Medical University. We are also working about anemia in Kaski district. Hira Madam, you mentioned hemoglobin level measurement using small portable device in field. So if you can, could you please tell us about the model of the device? And also future steps, you mentioned about field testing non-invasive hemoglobin measuring device. So as far as I know, one device using a light, using a finger, Sysmex, the company name, is that the one?
Thank you so much for your questions. And basically there is two questions you asked. One is methodology of the altitude corrections. And one, normally hemoglobin level is collection by the general method. Either you can collect in the lab or you can use the devices, hemoglobin test devices, like we use one devices. This is just a fingerprint, print. And after that, normally what we do in the field, after, and even in the lab, after you hemoglobin test, whatever comes is the final result. That's how is our normal practice in the clinic and even by the practitioner. And we use the treatment according to the finding. Basically, new recommendation of the WHO 2022, that's not the correct way. There are other factors you need to be revisited and reconsider to finalize final diagnostic and initiate the treatment of the hemoglobin anemia. And basically, especially this normal hemoglobin test divides and normal rates, they only can comes like if that's current level of hemoglobin measures for the sea level, But actual measures, if you go the higher, and there are altitude measures has been taken to the consider. That's a guideline. WHO has produced a new guideline. Based on the guideline, you need to adjust the finding. And based on the location of the and altitude of the patient they come from, and you can get that formula. There's a formula, like it starts from the above 1,000 meter to 4,000 meter, and you need to, there is a certain formula, after your like final finding, need to adjust with that WHO recommended formula. That's one recommendation. Another recommendation, even alcohol use. And that's again the very complicated, and maybe recommendation is there in the WHO. Even when you detect the anemia, again you need to have for like uptake of how many milliliter, what type of alcohol they the person consume per day. That's also determined. They have also adjustment formula. That's what we need to follow the new guideline of the anemia diagnostic treatment of WHO. And that's the one question. So I hope I answered it. And another question you asked is the non-invasive. That's the one university has kind of investing that device. That's the small mobile device, mobile apps. If you scan your retina, and automatically the mobile can read your hemoglobin level. And you don't need to prick and you don't need to blood on that. That is being tested in the different part of even the Bardia here in Nepal and different other countries. Maybe this paper is coming soon, and that is we are waiting, because again culturally everyone is fear to have a pricking and blood giving. That might be the groundbreaking. Thank you.
Yes, thank you very much. La, अब अर्को next questions. La, हजुर दुर्गा म्याम.
सबैलाई नमस्कार. सर्वप्रथम सबैजना प्रेजेन्टरहरूलाई चाहिँ एकदमै यङ जेनेरेसन, अब मेरो त अब नातिनी त भन्न मिल्दैन, छोरीहरूसम्म भन्न मिल्ला, त्यो एजको हुनुहुन्छ. तपाईँ त साथी भइहाल्नुभयो, हिरा म्याडम साथी भइहाल्नुभयो, हामी सँगै काम गरेको पनि हो. म प्रोफेसर दुर्गा खड्का मिश्र, म डिन मदनमोहन स्वास्थ्य विज्ञान प्रतिष्ठान हेटौडामा कार्यरत छु. र तपाईँहरूको यो बाइचान्स म यहाँ पसेको ठिक गरेछु यो ठाउँमा. अनि यङ जेनेरेसनले यति राम्रो रिसर्च गरेर चाहिँ यो देशलाई केही दिन खोजिरहेको मैले महसुस गरेँ. यसलाई धेरै धेरै बधाई पनि छ. र तपाईँहरूले जे कुरा खोजिरहनु भएको छ होइन, यो चिज चाहिँ कति चिज चाहिँ नेपालको ट्रेडिसनल कल्चरल फुडहरू, हाम्रो जुन ट्रेडिसन छ त्यो चाहिँ अब यो हाम्रो ट्रेडिसन छ भनेर यो कुरा अलिकति सर्भिसमा ल्याउन साथै त्यसलाई कसरी पेटेन्ट राइट अर्कोले बनाउने भनेर अर्कोतिर अर्को खेल हुनसक्छ जस्तो मलाई लाग्यो होइन. त्यसले गर्दाखेरि यस्तो टेक्नोलोजी यहाँ डेभलप गर्न जरुरी भयो कि अब त्यसलाई हाम्रो नै ओरिजिनल फुड हो होइन. यसमा चाहिँ यसको न्युट्रिसन भ्यालु यो छ. त्यसमा केही मोडिफिकेसन मेबी हाम्रो हाइजिनिक प्र्याक्टिसका कुराहरू, हाम्रो पानी नै कस्तो छ होइन, गुन्द्रुक बनाउने तर पानी कस्तो युज गर्ने होइन, कसरी ह्यान्डलिङ गर्ने, कति साग टिपेर ल्याएदेखि पकाउने बेलासम्मका हाम्रो ह्यान्डलिङ प्र्याक्टिसहरू कस्तो छ होइन. त्यसले चाहिँ भनौँ त्यसलाई इन्फ्लुएन्स गरेको हुनसक्छ. भनेपछि त्यस्तो खालको टेक्नोलोजी पनि हामीले डेभलप गरौँ. यहाँ मात्र होइन, बाहिरतिरबाट आएका फुडलाई पनि हामीले चाहिँ एउटा एसिस्ट गर्न सकौँ र हाम्रो ओरिजिनल चिजहरूलाई चाहिँ हामीले आफ्नो पेटेन्ट उसमा राख्न सकौँ भन्ने एउटा चाहिँ मलाई लागेको, त्यो होला सोचाइ भइरह होला एउटा कुरा. र अर्को चाहिँ मलाई लागेको के यहाँ प्रेजेन्टर साथीहरूले चाहिँ अब मेबी उहाँहरू पहिलो भर्खरको पनि हुन सक्नुहुन्छ. कति चिजहरू एउटा एनएचआरसीले गाइडलाइन दिएको थियो होला, कस्तो खालको प्रेजेन्टेसनमा केमा बढी फोकस गर्ने भनेर, कसैको मेथोडोलोजीमा बढी फोकस देखिएको थियो, कसैको रिजल्ट. यहाँ सबैजना चाहिँ हामी मेथोडोलोजी जसरी तपाईँहरूले गरेर ल्याउनु भयो होला भन्नुहुन्छ, तर रिजल्टमा त्यसको कन्क्लुजनमा त्यसको रिकमेन्डेसन के आयो होला भन्ने चाहिँ हामीलाई लाग्छ. त्यसले गर्दा केही साथीहरूलाई मेरो फिडब्याक चाहिँ हामीले चाहिँ हाम्रो रिजल्ट अब्जेक्टिभ के थियो र रिजल्ट र रिकमेन्डेसनमा चाहिँ बढी फोकस भएर यो कन्ट्रीमा पोलिसी लेभलमा के चाहिँ हामीले चाहिँ रिकमेन्ड गर्न सक्छौँ भन्ने कुराहरू सायद यही खोजी भएरै एनएचआरसीले यस्ता खालको समिटहरू पनि गर्ने गर्छ भन्ने लागेको छ. र यहाँलाई धेरै धेरै बधाई छ. थ्याङ्क यू.
हस् त, हस्, धन्यवाद. ल, कसैको अरू कसैको क्वेसन छ? हेर्नुहोस् है, अहिले क्वेसन सोध्न पाइएन अघिल्लो सेसनमा. अहिले अब मैले अहिले 6 जना भनेछु, 7 वटा प्रेजेन्टेसन हो. हाम्रो रुद्र सरलाई चाहिँ बिर्सेछु फेरि. मैले लेडिजलाई मात्रै 6 वटा भनेछु मैले. हजुर भन्नु. यहाँ छ. प्लिज.
And basically बिहान प्लेनरी हुँदाखेरि चाहिँ जहिले पनि अल मेल, वेयर इज अ फिमेल होइन, लिडरसिपमा अलवेज वाइ मेल भन्ने कुरा आएको थियो. अहिले यो यङ जेनेरेसन फर्गेट मी रुद्रजी. तर अहिले हेर्दा आइ एम सो इम्प्रेसिभ होइन, यङ जेनेरेसन एन्ड फिमेल इज लिडिङ द वर्ल्ड भन्ने हिसाबले आइ एम सो इम्प्रेस्ड.
एकदम पक्कै हो. होइन, त्यो तपाईँ अरू कन्ट्रीमा, डेभलप कन्ट्रीमा पनि देखिएको छ. म यो नेदरल्यान्डमा पढ्दै गर्दा हाम्रो प्रोफेसरले के भन्नुहुन्थ्यो भने इभन युरोपमा चाहिँ अहिले वुमनहरूको लिडरसिप विभिन्न इन्स्टिट्युसनमा युनिभर्सिटीमा विभिन्न ठुलो एडमिनिस्ट्रेटिभ उसमा अरू उसमा चाहिँ मेनहरू चाहिँ ब्याचलर्स गरेपछि नपढ्ने, उनीहरू वर्कमा गर्ने अर्निङमा लाउने, र वुमनहरूको चाहिँ ठ्याक्कै एकदमै सिग्निफिकेन्टली एकदम के त्यो हायर इन्क्रिजिङ उसमा चाहिँ देखाउनु भएको थियो। यति राम्रो एउटा इन्डिकेसन चाहिँ त्यो अन्त पनि हुँदैछ, अब अहिले यहाँ पनि हुँदैछ भन्ने देखिन्छ। ल कसैको यदि यहाँहरूको ठ्याक्कै त्यो बर्निङ इस्यु कुनै क्वेसन्सहरू छैन भने म हाम्रो आदरणीय सुवेदी सरलाई केही कुराहरू भनेर केही अब मार्गनिर्देशन र अब हाम्रा गभर्मेन्टको पोलिसी प्रोग्रामहरू हजुरलाई पक्कै पनि थाहा छ। हाम्रो मल्टी सेक्टरल न्युट्रिसन प्लान भनेर फर्स्ट, सेकेन्ड, अहिले थर्ड 2023 देखि 2030 सम्मको पनि एउटा हामीसँग 7वटा लाइन मिनिस्ट्रीले राष्ट्रिय योजना आयोगको लिडरसिपमा 7वटा मिनिस्ट्रीहरू छन्। सबै मिनिस्ट्रीले आफ्नो के अरे सेक्टरमा यी प्रोग्रामहरूलाई यो मालन्युट्रिसनलाई कम्ब्याट गर्नको लागि कसरी चाहिँ मल्टी सेक्टरली विभिन्न एप्रोचमा काम गर्नुपर्छ भनेर पनि असाध्यै राम्रो, एकदमै राम्रो यो हाम्रो पहिलो र दोस्रोको सिकाइ अनुसार पनि अहिले पनि डकुमेन्टहरू छ। र अब अर्को हजुरहरूले पक्कै हेर्नुभयो होला, अहिले एउटा न्युट्रिसनको पनि हामीले एनडिएचएसको न्युट्रिसनको डाटाको फर्दर एनालाइसिस गरेका छौँ। एउटा म पनि गरेको छु, म त्यसको एउटा मेम्बर हो। त्यो फर्दर एनालाइसिसमा पनि के देखिया छ त भन्दा अब हामीले यो कपिल वस्तुमा चाहिँ किन वेस्टिङको रेट बढी देखियो, हजुरले यदि हेर्नुहुन्छ भने त्यो आउटलायर जस्तो छ नि 16, अन्त 10 छ त्यहाँ 16 छ, किन त्यस्तो देखियो भनेर हेर्दाखेरि डिफ्रेन्टली हामी भेरिएबल्सहरू हेऱ्यौँ। त्यहाँ नम्बर अफ चिल्ड्रन, एजुकेसन अफ मदर, अनि अब एट बर्थ चाहिँ त्यो एलबिडब्ल्यूका कुराहरू, अनि पोभर्टीको सिचुएसन, इन्भाइरोमेन्टको सिचुएसन, सबै कुरा हेर्दा मधेस प्रोभिन्स र लुम्बिनी प्रोभिन्समा चाहिँ धेरै न्युट्रिसनको इन्डिकेटरहरू यो लो हुनमा चाहिँ यो समाउ सिग्निफिकेन्ट छ भन्ने देखियो। यो मन्त्रालयको यो वेबसाइटमा छ, डिटेल्स अब 100 कति पेजकै छ। हजुरहरूलाई यो पक्कै पनि यो उसको लागि पनि काम लाग्छ, एकाडेमिक उसमा पनि, र भोलि कुनै कुराहरूमा अझै फर्दर केही गर्नु पऱ्यो भने कुरा लाग्छ। ल म यति भन्दै मैले यो सम्पूर्ण यसको चाहिँ सेसनको पनि क्लोज गरिदिनु हुनको लागि र केही निर्देशनहरू र गभर्मेन्टको राष्ट्रिय योजना आयोगमा जुन नेतृत्व गरिरहनु भएको सरलाई अरू पनि फर्दर मैले भन्न छुटेका, मैले धेरै कुरा सुरुमै अलिअलि ब्याकग्राउन्डमा पनि कुरा गरेँ र प्रेजेन्टेसन वाइज पनि मैले कुरा गर्दैन, म धेरै भनेर ल म हजुरलाई केही भनिदिएर सेसन पनि अन्त्य गरिदिनुलाई र पुनः सबैलाई धन्यवाद दिनुलाई पनि अनुरोध गर्न चाहन्छु। हस् त, धन्यवाद, नमस्ते।
हस्, धन्यवाद दिला सर। यो महत्त्वपूर्ण कार्यक्रममा उपस्थित हुनुभएका सम्पूर्ण म्याडम तथा सरहरू सम्पूर्णमा नमस्कार। म हेमराज सुवेदी, राष्ट्रिय योजना आयोगमा सहसचिवमा काम गर्छु र यो नेपाल स्वास्थ्य अनुसन्धान परिषदको एउटा बोर्ड मेम्बर पनि भएको नाताले म यहाँहरूसँग आज उपस्थित भएर यहाँहरूका कुराहरू सुन्ने र आफ्ना कुराहरू पनि सुनाउने मौका पाएको छु। वास्तवमा रियल्ली मैले आज एकदम इन्जोय गरेँ। म साँच्चै रिसर्च फिल्डको मान्छे होइन, त्यसले गर्दा मलाई अझ बढी इन्जोय भयो कि जस्तो लागेको छ। र आजको 7 जनाको प्रस्तुतिमा 6 जना फिमेल, 1 जना मेल। मेल चाहिँ अलि ओल्ड एज, तर फिमेलहरू एकदम चाहिँ भर्खरको चाहिँ एउटा युवा पिँढीहरूको चाहिँ यो प्रगति देख्दाखेरि अत्यन्तै राम्रो र हाम्रो देशले पनि थुप्रै प्रगति गर्दैछ है भन्ने एउटा चाहिँ एउटा पोजिटिभ मेसेज चाहिँ मैले पाउन सकेँ। वास्तवमा यहाँहरूले गरेका जुन रिसर्चका कन्टेन्टहरू छ नि, त्यो कन्टेन्टहरूले पनि धेरै विषयहरू यहाँले राख्नुभएको छ। हो, वास्तवमा 10 मिनटको समयमा धेरै कुरा प्रस्तुत गर्न सकिँदैन। त्यसमा त्यो एउटा स्किलको पनि खाँचो पर्छ र एउटा फर्मेटमा पनि तपाईँहरू जानुपर्ने भयो हुनाले 10 मिनटभित्र धेरै कुराहरू ल्याउन नसके पनि तर मेन कुराहरू आएको छ। अगाडि हरेक लीला सरले पनि केही न केही कुराहरू 1-2 सेन्टेन्सहरू पनि थपेर्नु पनि भएको छ। र यहाँहरूका सम्पूर्ण प्रस्तुतिहरू मलाई चाहिँ सबै नै उहाँहरूले यो गरेको भए हुन्थ्यो कि अथवा यस्तो नगरेको भए हुन्थ्यो कि भन्ने मलाई लागेन। उहाँहरूले चाहिँ जे गर्नुपर्ने थियो एउटा फर्मेटभित्र बसेर गर्नुभएको छ। उहाँहरू सबै यसमा सफल हुनुहुन्छ र मैले चाहिँ यो एनएचआरसीले के गरिरहेछ यति धेरै मैले यो कन्टेन्ट हेर्दाखेरि अलि के मलाई चाहिँ यो धेरै क्राउड हो कि जस्तो पनि लागिरहेको थियो। तर यो हलमा त हामी धेरै क्राउड पनि भनौँ, एकदम सबैजनाले एउटा सक्रिय सहभागिता जनाउने अवस्था पनि रह्यो। खास गरिकन यहाँ आएका सम्पूर्ण विषयहरू फुड सिस्टमका विषय, हेल्थका विषय र न्युट्रिसनसँग सम्बन्धित विषयहरू आए आजको 7वटा विषयमा। यी विषयहरू मल्टिसेक्टरल सबै क्रस कटिङ इस्यु हो। यसमा कुनै एउटा निकाय, संस्था, मन्त्रालय अथवा क्षेत्रले मात्रै यसलाई इन्टरभेन्सन गर्न सक्दैन। यसको लागि निजी क्षेत्रदेखि सरकारी क्षेत्र सबै क्षेत्रको अत्यन्तै महत्त्वपूर्ण भूमिका रहन्छ। राष्ट्रिय अन्तर्राष्ट्रिय हाम्रा विकास सहायताहरूले पनि यसमा महत्त्वपूर्ण भूमिका निभाउनु भएको छ। र यसरी नै हामीले पनि 2टा मन्त्रालय वा सोभन्दा बढी मन्त्रालयको समन्वय गर्नु पर्यो भने राष्ट्रिय योजना आयोगले कोअर्डिनेसन गर्छ। र त्यही सिलसिलामा यो के भन्छ MSNP मल्टिसेक्टर न्युट्रिसन जुन प्लान छ यसलाई पनि राष्ट्रिय योजना आयोगले एउटा समन्वय गरेको छ। वास्तवमा राष्ट्रिय योजना आयोग आफैले कार्यान्वयन त गर्दैन, सबै मन्त्रालयहरूले कार्यान्वयन गर्ने हो, तर उसले समन्वय गर्छ, कोअर्डिनेसन गर्छ र सबैलाई परिचालन पनि गर्छ र के भयो के भएन भनेर अनुगमन पनि गर्छ। यसले गर्दाखेरि सबै मन्त्रालयहरूले गर्ने काममा राष्ट्रिय योजना आयोगले चाहिँ यसरी थप भ्यालु एडिसन गर्नलाई मद्दत पुर्याएको हुन्छ। हामीले थुप्रै कुराहरू यहाँ सुन्यौँ। ती कुराहरू हाम्रो लाइफको सुरुवाती चरणबाट बच्चाको अवस्थादेखिबाटै हामीले परिमार्जन गर्नुपर्ने, त्यो भनेको परिवारबाट होला अथवा स्कुलबाट गर्नुपर्ने परिवर्तन गर्नुपर्ने विषयहरू, व्यवहार परिवर्तनका विषयहरू जुन यहाँ आएका छन् ती विषयहरू चाहिँ हामीले ती सेक्टरमा त्यो ठाउँमा सानैबाट घरमा बुवा आमाले भनेको भन्दा मिसले भनेको कुरा बच्चाहरूलाई जति रियलाइबल हुन्छ त्यसरी नै हामीले पाठ्यक्रममा पार्दै समावेश गर्दै जाने क्रममा पनि छौँ। त्यसरी जाँदाखेरि भोलिका बालबालिकाले ती उनीहरूबाट चाहिँ यी सानैबाट त्यस्तो महत्त्वपूर्ण विषयहरू सिक्दै आउँछन् जुन कुरा हामीले विगतमा सिक्न पाएका थिएनौँ। त्यस्ता कुराहरू आजका बालबालिकाले सानैबाट सिकिरहेको देखिन्छ। अहिले डे स्कुल मिल प्रोग्रामको चाहिँ शिक्षा मन्त्रालयबाट करिब वर्षमा 8 अरब जतिको चाहिँ लगानी भएको छ, खर्च भएको छ। त्यसलाई खर्च नभनौँ, लगानी नै भनौँ। त्यसमा पनि राष्ट्रिय योजना आयोग र शिक्षा मन्त्रालय मिलेर अहिलेसम्म भएकोमा विभिन्न ठाउँमा मोडालिटीहरू फरक छ। कस्तो मोडल चाहिँ एकदम उपयुक्त मोडल होला, कुन मोडलमा बसेर काम गर्दा अझै यसलाई इफेक्टिभ लान सकिन्छ भनेर इन्टरनल इभ्यालुएसन पनि गरिरहेछौँ। त्यो कुरा पनि कतै न कतै यसमा जोडिएको देखियो। हामीले चाहिँ त्यसमा शिक्षा मन्त्रालयले पनि यसलाई हामीलाई संयुक्त रूपमा यो कामहरू गरिरहेको हुनाले केही जिल्लाहरूमा ठाउँमा पुगेर पनि हामी यथार्थता हेर्छौँ। कतिपय ठाउँमा के छ भने केही पालिकाले के थपेर पनि राखिदिएको छ, कोही ठाउँमा अझै पनि क्यासकै रूपमा नभइकन क्यासको रूपमा पनि दिएको देखिएको छ। कोही ठाउँमा उनीहरू चाहिँ सामूहिक रूपमा बिग मिल अथवा चाहिँ ग्रान्ड मिलको रूपमा पनि किचनको रूपमा ग्रान्ड किचनको रूपमा चाहिँ उपलब्ध गराएको देखिन्छ। यसले गर्दा विभिन्न प्रकारका मोडलमा उहाँहरूले गरेको मध्ये कसरी आगामी दिनमा अझ बेस्ट मोडलमा जान सकिन्छ भन्ने हिसाबमा पनि हामीले हेरिरहेको अवस्था छ। र यहाँहरूलाई जानकारी छ यी समग्र विषयहरूलाई हामीले 16औं राष्ट्रिय योजनामा समावेश गरेका छौँ। 16औं योजनाको रणनीति र यसका विषयगत कार्यक्रमहरूमा हामीले यहाँ जति विषयहरू उठेका छन् ती विषयहरू समावेश भएका छन् र तिनलाई हरेक मन्त्रालयले आफ्नो वार्षिक कार्यक्रममा र बजेटमा पारेर ती कार्यान्वयन हुँदै जाने अवस्था हो। र यहाँहरूलाई जानकारी गराउन चाहन्छु निकट भविष्यमा हामी आगामी वर्षको वार्षिक कार्यक्रम र बजेटको तयारीमा छौँ। यहाँ आएका कतिपय विषयहरूले हामीलाई चाहिँ ती तीनमा चाहिँ रूपान्तरण गर्नलाई पनि ती विषयहरू महत्त्वपूर्ण हुने हुनाले यहाँहरूले जे जस्ता प्रस्तुति गर्नुभयो, यहाँहरूले जे रिसर्च गर्नुभयो त्यसले महत्त्वपूर्ण भूमिका दिनेछ भन्ने कुरामा म विश्वस्त छु। र अन्त्यमा मैले यहाँ धेरै भनिरहनु पर्ने छैन, तपाईँहरू आफू जानकार हुनुहुन्छ। जसले प्रस्तुत गर्नुभयो उहाँहरू जानकार नै हुनुहुन्छ। जसले यहाँ श्रोताको रूपमा सहभागिता हुनुहुन्छ उहाँहरू झन् जानकार राख्ने मान्छेहरू व्यक्तित्वहरू हुनुहुन्छ। अन्त्यमा आजको यो रिसर्च पेपरमा प्रस्तुत गर्ने साथीहरू, सहभागी साथीहरू र सम्पूर्णलाई यो आउँदै गरेको नयाँ वर्ष 2082को सन्दर्भमा यहाँहरू सबैलाई उत्तरोत्तर प्रगतिको हार्दिक मङ्गलमय शुभकामना व्यक्त गर्न चाहन्छु। र आगामी वर्ष यहाँहरूले रिसर्चको सेक्टरमा अझै महत्त्वपूर्ण योगदान तपाईँहरूले दिन सकोस् र हामीले रिसर्चमा हामी अझै पनि पछि छौँ। त्यो जुन पछि भएको कुरालाई हामीले अगाडि जान सकौँ भन्ने शुभकामना दिँदै एनएचआरसीले जुन यो कार्यक्रम गरेर हामीलाई पनि यहाँ एउटा त्यो प्यानलिस्टमा समावेश गर्ने मौका यो मौका दिनुभएको छ। उहाँहरूलाई पनि हार्दिक धन्यवाद दिँदै मेरा कलिग्स लीला विक्रम थापाज्यूले सुरुबाटै जति यसमा चाहिँ योगदान पुर्याउनु भएको छ उहाँलाई पनि धन्यवाद भन्दै हाम्रो यो सेसन समाप्त भएको बेहोरा म यहाँलाई जानकारी गराउन चाहन्छु। धन्यवाद, नमस्कार।
Well, thank you to all our presenters for taking an opportunity to present your study in our 11th National Summit. And thanks to our chair, Mr. Lila Bikram Thapa sir, for making it more informative, and to our Mr. Hemraj Subedi sir for such an heartwarming closing remarks. So without further ado, I would like to express our appreciation. Appreciations, I now request our session chairs to present token of gratitude to each of our presenters. So as I call out your name, I request you to come forward on the stage. So token of appreciation, please. So firstly, we have Ms. Leela Khanal ma'am. May I please request Ms. Leela ma'am to be on the stage. Likewise, next we have Ms. Kusha Gurung. Next, we have Mr. Rudra Bahadur Nyopane. Likewise, we have Ms. Anjita Khadka. Next, we have Neha Malla, Ms. Neha Malla. Likewise, we have Ms. Anusha Acharya. And last but not the least, Ms. Arya Gautam. Thank you once again for your dedicated and valuable contribution. Now I would like to invite Professor Durga Khadka Mishra Ma'am, Dean of the Madan Bhandari Academy of Health Science, to provide the token of appreciation to our respected chairs. Likewise, to our sir, Mr. Hemraj Subedi. Thank you so much. We still have one last thing to do, that is to take a group photo. May I please request once again to all our presenters to come up on the stage for a group photo.